is everybody today? I hope everybody's having a great morning. I'm sorry about yesterday, guys. I was so tired. Hi, my name is Debbie. Welcome to my channel. We are on day 85 of, well, I should say part 85. I don't know what day we're actually on, of the Phil Spector trial. His first trial ended in a hung jury. It is was in the year 2007. Phil Spector killed actress Lana Clarkson, and Judy, as always, has trivia for us. Michael Bay was he the last witness we saw? I think he was the last witness that we saw. Michael Bay is an American film director and producer. He is best known for making big budget, high concept action films with fast cutting, stylistic cinematography and visuals. On May 23rd, 2017, Bay was honored with his own hand and I didn't know that. Cool. Bay on May 23rd, 2017, Bay was honored with his own hand and footprint ceremony at the TCL Chinese Theater. His English Mastiff Rebel put her paw in the cement with him. Oh, cool. Bay lived with his 3 English Mastiffs named for characters in his films. In a 2016 Rolling Stone interview, Bay said that his net worth was around $500 million. Wow. Wow. Man, that sucks. I was a nurse, and I saved lives, and I'm broke. Yeah, and I'm a cancer survivor. That's why I'm broke. Being sick is not cheap, y'all. That sucks, man. Anyway, today, who is our first witness today? Our first witness today is Dr. Jan Leestma. So he is going to be our first witness. We have 2 hours of him. Forensic neuropathologist. So let's get ready for an exciting expert witness. Yay!
Ladies and gentlemen, thank you.
Please raise your right hand to be sworn. You solemnly swear that the testimony you may give and the cause now pending before this court shall be the truth, the whole truth, and nothing but the truth, so help you God.
I do.
Thank you. Please be seated in the witness stand. Please state and spell your first and last name.
Leestma. Sir, how are you employed? How are you employed, sir? Just fine. Pardon me? How are you employed? What's your...
Oh, I'm self-employed at the moment.
Okay, and what's your occupation, sir?
I'm a neuropathologist.
Okay, and how long have you been in the field of neuropathology?
Oh, from, let's see, approximately 1968 till present. That's when I completed my neuropathology training, so.
Could you tell the members of the jury just a kind of an overview of what the field of neuropathology...
Well, if you will, within the field of pathology.
StreamYard, I am not in the mood today. We just started.
Is the study of human disease, how it works, how it plays itself out, what causes diseases, what to trauma, to an infection. All of that is fair game, trying to understand how that process works. And neuropathology would be a focus of that, with nerves and to some degree muscle. And some have included that.
So this is sort of a subspecialty of the field of pathology.
Yes.
And in order to subspecialize in this specialized field, what background education do you have to have? I take it you go to medical school first, and if you could explain to the jury what your educational background is.
Virtually everybody who attends medical school has had a college degree, and I'm no exception, 4 years of college. And went to medical school, which in most places is a 4-year curriculum, which I did too, at the University of Michigan in Ann Arbor. And then following that, training can vary somewhat, but in my case, I went directly into the field of pathology, and I did that at the University of Colorado School of Medicine in Denver, where the first 2 years of my training were devoted to general pathology, or anatomic pathology as it's called. And that has to do with, you learn how to perform an autopsy. You learn how to examine tissues from an operating room and make frozen section diagnosis, things of that sort. So I spent 2 years doing that and beginning my research career and so forth and so on. I decided then I wanted to do neuropathology, which requires, at that time, an additional 2 years of training, which is more focused, of course, with the brain. And I did the first of those years at Denver, and then I transferred to the Albert Einstein College of Medicine in the Bronx, New York, for the last year of my neuropathology training.
After you finished your training in this subspecialty of neuropathology, did you engage in any practice of neuropathology in the United States military?
Yes, I did.
Could you explain to the jury what that is?
Right. Yeah, I finished my formal pathology and neuropathology training in 1968, entered the United States Air Force Medical Corps as a captain, and was assigned to the Armed Forces Institute of Pathology in Washington, D.C. It's an all-service organization on the Walter Reed Army Medical Center campus. And I spent 3 years in that institution, honorably discharged in 1971 with the rank of Major, Air Force Medical Corps.
What type of neuropathology work did you do for the Armed Forces Institute of Pathology in the position you just explained?
Well, it turns like the military, the first year, somebody decided that they needed me in another specialty than what I was doing, so that's what I did, genitourinary pathology, which is fine. At the end of that time, I was transferred into the neuropathology branch, which is the practice of neuropathology. Would be performing autopsies, sometimes full autopsies, brain autopsies, providing consultative services to the armed forces. We were engaged in the Vietnam conflict at that time, so there were a lot of strange, unfamiliar diseases that were affecting the U.S. troops, and they would send materials back to the FIP, or Armed Forces Institute of Pathology, for diagnosis. And there you are. Whatever comes into, you try to diagnose it, try to write a report, and that's it was very good against seeing an unbelievable material. Okay,
you mentioned in one of your answers, Dr. Lietzman, that you started to do research in certain areas. Have you continued to do that in your career?
Sure.
What areas of research have you focused on?
Well, at the time, this would be in the middle 1960s, a tool that became very, very popular and very valuable was the electron microscope. So I learned how to drive that machine and use it for studies primarily of viral diseases of the nervous system, herpes simplex, for example, rabies, had some cases of those things. And then moved on, developing an interest in some processes that are probably involved in Alzheimer's disease. And I proceeded to then get some training and experience and work in some of that area, again, applying the electron microscope and some other laboratory techniques to try to get some notions about what was going on there.
I don't want to get into all of your publications, but over the years that you've been in this specialized field, have you published in this field?
Yes, my publications, I think, are a little over 100 now, reflect what I was doing at the time. I mean, there would be viral research types of things, cases of one kind or another, and so forth. Up until the present time, I'm still writing articles and book chapters and things like that.
Yeah, Dr. Leetsma, in your background, have you ever been licensed to practice medicine in any state or jurisdictions?
Yes.
And could you tell the jury what those are?
During my training, I had temporary license in Colorado, and for the 1 year I was in New York City, I had a temporary license there. In the military, it wasn't required, and so I have permanent licenses now in the state of Illinois, where I live, and in the state of Michigan.
Okay. Do you have any board certifications in the field of pathology?
Yes, sir, I do.
What is that?
I am certified in anatomic pathology by the American Board of Pathology and in neuropathology. They're two separate certifications, and I hold them both.
Okay, and I take it that you have to qualify and take tests to become board certified?
Yes, the board, like any medical specialty in the country, are presumably the leaders of the field, and they stipulate, well, here's what a proper training for someone like yourself should be. They license and accredit training programs, and so if you want to be certified, you better go to one of those licensed programs, and you do what they require you do, and you make the application to the board, and when you've completed the requirements, then you take some examinations, which in our case was a three-day marathon, and at the end of that, if you pass it, then you get a certification for the board.
And have you been board certified by the American Board of Pathology in both anatomic and neuropathology since 1970?
Right.
Okay. So you've maintained your certification?
Yeah, now they've changed this. At the time that I was certified, recertification wasn't part of the game. People coming through the training programs now would have, every 10 years, would have to engage in some sort of recertification. I am a grandfather, and I'm grandfathered on this one, so I won't have to be doing that.
Dr. Leetsma, during your career, have you had any academic appointments, and if so, what are they?
Right. It began in Colorado. I was an instructor in the Department of Pathology there while I was a resident. And then the formal appointments, I had informal appointments, or at least temporary ones, when I was in Washington, D.C. at Georgetown and some of the other schools there and the military hospitals. I've had academic appointments when I took my first job, so to speak, at Northwestern University in Chicago, the medical school, and came in as an assistant professor and ultimately left that institution as a tenured associate professor. I then became a full professor at the University of Chicago, and when I left there, well, that's what I attained. And I had hospital privileges and so forth at all of the satellite institutions for these places.
What are hospital privileges, if you can briefly explain that to a...
Well, it means that I can, as a pathologist, I'm not admitting patients, I'm not treating patients or, seeing them on a day-to-day basis at all. I'm a consultant to the other doctors, but it enables me to have the credentials and the wherewithal to enter those institutions, sign reports, perform the work of what a pathologist would do in those institutions. And that's a formal process. I mean, you just don't walk in the door. They have to accredit you, make sure you know what you're doing and you're properly certified and all of that.
Okay, and so you were a full professor at one point. Do you still teach, or are you retired from that?
I'm, at this point, retired from hospital practice and self-employed as a consultant, but I still teach, still lecture. It's on somebody else's pleasure if they invite me to come and give a lecture to the medical students or whoever. I would be happy to do that, and I do.
Dr. Lietzma, in your work in this particular field, do you have any special training or experience in the field of forensic pathology as it relates to your specialty of being a neuropathologist?
Yes.
What is that?
There is, in a sense, when I was coming along now, there might be some sort of informal training programs in so-called forensic neuropathology. But basically, one gets in the basic of forensic pathology, which I did. I took some scholarship and training our leaders, paying attention to what other people are saying and read the books and read the papers and get there and do the work. And pretty soon hopefully you know what you're doing.
Dr. Lietzma, have you had any affiliation with the coroner's office or medical examiner's office in your background? What is that?
I have. From the middle 70s to the middle 80s, I was the consultant neuropathologist to the Cook County Medical Examiner in Chicago. Cook County includes the city of Chicago. And so I was there on a part-time basis virtually every week to help the pathologists do their work. And I would examine brain specimens, and sometimes be present at an autopsy by their request to help them get their work done. I also had an appointment at the Forensic Science Institute in San Juan, Puerto Rico for a period of time.
Dr. Lietzma, the field of forensic neuropathology is, am I correct in understanding that you don't actually do the autopsies generally, but that you just consult with them and do specialized portions of it? That's
true. I mean, I'm certainly qualified to do an autopsy and a forensic one at that, but that isn't what I do. Usually that autopsy exam is done by somebody else, and the brain specimen would be retained for a later examination by someone like me.
Okay. So give the members of the jury just an example of the type of consulting work and forensic pathology work that a person with your qualifications would do.
Yeah, I'd be called in to examine the brain and microscopic slides if that's appropriate, generate a report, and work with the forensic pathologists to enable them to determine cause and manner of death and whatever else might be important to them.
Okay, as it relates to your particular field.
That's right.
Okay. Dr. Lietzma, have you published any books in the area of forensic neuropathology?
Yes.
Okay, what was the publication that you published?
This was a book, about a 450-page work that was published in 1988 by Raven Press in New York, a medical book publisher, and the title was Forensic Neuropathology. And, so that book is now out of print, but I'm heavily engaged in rewriting that for a second edition, which I hope will be done in a few months.
When that book was originally published, was it the only forensic neuropathology book that anybody had published at the time?
Correct.
And what type of circulation did the book get? Who was interested in that book, if anyone?
Well, clearly forensic pathologists would be, and a goodly number of them apparently purchased the book. Medical examiners or coroner's offices might well have it in their library. Medical school libraries made up a significant bulk of the sales worldwide, really. And then there would be a scattering of other people, attorneys, I suppose, and other folks who might have some interest in this field would buy that book. It wouldn't be a medical school textbook because this is kind of arcane and off the side of normal medical education.
Dr. Leitsma, you were asked to consult with the attorneys for Mr. Spector on certain neuropathology issues in this case, is that correct?
I was.
And you were provided with some materials, including an autopsy report of a Dr. Lois Pena. Is that true?
That's true.
And then you looked through those records that he generated from his autopsy?
Yes.
And did you also, were you provided and did you review the photo documentation of the autopsy, what the pictures they take?
Yes, those and some scene photographs, and quite a lot of them, but I was shown those things.
Okay, and I want to ask you some questions about your consultation in this particular case. And what I would first like to do is ask you if it is correct in my understanding that this consultation related to the death of Lana Clarkson and what effect the damage to her spinal cord had.
This was pretty much the focus of the issue, as I understand it, yes.
Okay, Dr. Leitsma, in reviewing the materials that you reviewed, could you explain to the jury what damage to Ms. Clarkson's spinal cord occurred? In other words, if you could explain
Sure.
how that happened and what occurred.
Okay. Upon virtually at the moment of discharge of this pistol, the projectile or the bullet went to the back, basically the back of the mouth, penetrated the skull-based skeleton, and just about at the junction between where the spinal skeleton, the cervical vertebrae, articulate with the base of the skull, and passed essentially very close to the midline, right through the junction between the medulla, which is the lowest part of the brainstem, and the upper cervical spinal cord. So it, in a sense, severed that and destroyed tissue there for probably an inch, as I could discern from the pictures. Then proceeded onward to shatter the back of the skull. And then the projectile came to rest under the scalp skin. There was some fragmentation, but basically it's pretty much of a straight trajectory from the back of the mouth, 3 inches or so, whatever it is. In the way was the spinal cord, as I've indicated, and that was severed.
Okay, what happens if a person's spinal cord is severed in the way that Ms. Clarkson's was severed after the result of this shot?
Usually, what would happen is that there's an immediate loss of control. In other words, all voluntary motor function, by motor I mean the ability to move your arms and legs and things, and breathe, would be interrupted at that point by the severance of all communications with the upper brain that could direct some of those activities, and other areas within the brainstem that have the immediate mechanical neural function to direct you to breathe and breathe in and breathe out and so forth and move. So that would cease. Usually with the kind of things that happen with the pressure wave that is attending a projectile entering the cranial compartment, consciousness is lost promptly, especially when you're near the brainstem, because that's where consciousness resides.
When you say pressure, what do you mean by that?
Well, there will almost inevitably be some carry forth of the gases of combustion and explosion, plus the pressure wave of a bullet passing into the cranial compartment will have pressure waves that emanate from that, like a stone thrown into a pond. You see these ripples that go out. And well, those ripples are forces, and they can disrupt brain tissue, turn it off. And so consciousness is usually, especially with a wound in this area, would be immediately lost.
Okay. Now I want to show you a picture, Defense Exhibit BB. ask you to take a look at that.
There you go.
You see this picture, Defense Exhibit BB, Dr. Lietzma?
I've seen this before, yes.
Okay, and this is one of the many pictures that you reviewed before testifying?
Correct.
You see the position that Ms. Clarkson is in at the time. Is it your understanding that this was the position that she was found in after law enforcement arrived?
That's my understanding, maybe with some minor position, but it's my understanding the body was not moved.
Okay. And Dr. Lietzma, is there any way to tell, based upon the nature of her injury to the spinal cord, whether or not there could have been any movement between the time she was shot and the time that she was found in this particular position?
Yes, it is possible.
And how is that possible given the nature of this particular injury?
Well, what we have to do is we cannot, in a sense, look at the facts that surround this particular person. We have to really step back a few spaces and go to the physiology and the anatomy of what has happened here and what that could mean. It's clear from the position of this body that the legs are extended out. And there's a question of how the body got in that position. And this is what I'm prepared to address.
Okay, and how does it get into this position after the shot is fired?
Assuming for the moment that the victim was sitting in the chair in roughly the position that I am, standard knees bent and feet on the floor and so forth and so on. This then reaching a position like this, of course, could be simply gravity and relaxation and so forth. But there's another possibility.
Okay.
And you want me to go into that?
Yeah, what is that other mechanism that you just mentioned?
That there could have been some reflex movements proximate to the passage of this bullet or immediately thereafter. Something called decerebrate, C-E-R-E-B-R-A-T-E, posturing,
Okay.
or rigidity.
What is that, if you could explain that to the members of the jury?
I think probably the best way to do that would be maybe some of the jury have this experience of taking a biology class where I don't know, they do it much anymore, but they sure did when I was a young student, is they would take a frog and in preparation for doing something, usually with the heart and seeing the heart beat and all that, they would essentially kill the frog, and they often did this by inserting a needle in the back of the head of the frog and kind of move it around. And this is called pithing, P-I-T-H-I-N-G. I don't know where that word came from, but that's the name that they did it. And usually at the moment of this not very pleasant activity, the frog would, if I can demonstrate, and I'll verbally do this too, is that they straighten out. The legs become extended and stiff. The upper extremities do the same thing, and often the head is thrown backwards. And then after that, depending on many variables, that posturing ceases, and then the animal, for all intents and purposes, can feel no more pain or anything, and is, in a sense, dead, and then you go ahead with your whatever you were going to do. This reflex, though I'm using a frog to illustrate that, is a reflex that is present in humans. And decerebrate posturing basically means that there's been a disconnection between the brain and the lower centers. And in a sense, what happens during that event, however the severance occurs, is that the lower spinal centers are released from control. And by that I mean, if I were sitting here and maybe there was a stone in my shoe, for example, there would be an impulse of my body involuntarily to twitch or do something to get away from that noxious stimulus. But since my brain is connected to that, there's a lot of inhibitory impulses that keep all this under control. But once that is released, the spinal cord can produce discharges that can include this so-called decerebrate posturing, which could result in the repositioning of this body to what we see it there.
Okay, so this phenomenon, or this is as a result of the spinal cord being severed, correct?
Well, it's enabled by the spinal cord being severed. Now, maybe the stimulus of the injury there could trigger this decerebrate posturing, or who knows what else. Sometimes it just occurs spontaneously from the uninhibited neural impulses that are there all the time.
Okay, so would impulses from the spinal cord to the muscles, et cetera, would they go to the muscles even though there was a disconnection to the brain?
Oh, yes, because if I don't know anybody knows much neuroanatomy, but as the spinal cord extends into the spinal canal, at about every half inch or so, or less, there are pairs of nerves that exit from the spinal cord and go out and innervate the body and provide sensory as well as motor impulses in the spinal cord shot wound. So the spinal cord, at least in an isolated sense, is functioning fine and can respond to reflexes, that is, stimuli out someplace, may prompt an involuntary automatic motor response that can include this complex posturing or could involve the spasm of one extremity or another.
Okay. Now, looking at Exhibit BB, is her position consistent with this movement after the injury? With the position she
Yes,
found?
I don't know precisely when. It could have been almost at the moment of this injury, or it could have been a second or two or something later. It's hard to predict, and I have no way to know that.
Okay. Now, you mentioned something about the blood supply still going to the spinal cord. How does that occur if somebody has basically had their spinal cord cut like Ms. Clarkson did in this particular case?
Well, obviously, by severing of the cord, you don't necessarily know what's going on with the blood supply, but I don't think it takes a genius to imagine that the blood supply coming to that area is going to be disrupted. The point being here is that the heart is still beating, and the heart would continue to beat for some period of time, hard to predict how long, and is going to keep doing its job. In other words, blood is going to be conveyed from the heart through the aorta, and branches of the aorta provide nourishment to the spinal cord. And so business as usual for a while anyway in terms of that.
Okay, so the heart still beats even though you've lost the connection to the brain.
That's right.
And that would mean that blood is going to the spinal cord and other areas of the body, except the areas that are injured by, let's say, the bullet. Is that correct?
Time until other processes come in that would either interfere with the heartbeat, stop the heart, or, and the chief.
Be specific. How long is a while? A while can be any amount of time, and I have a feeling a while is a very short amount of time. Because if you're shot in the brainstem, everything is not gonna just keep going. A while in that, and like you're, oh my god. Right? Right? Because, like, he just said your consciousness is in your brainstem, right? So if you get shot in your brainstem, that's you. Your brainstem controls everything. So, yeah, your heart is going to keep pumping until it realizes you don't have a brainstem anymore. So it's not a while, it's like seconds. It's not like a while, like I'll be there in a while, like minutes or hours or like a while. That's a relative term. Dude, I think you need to be a little more specific on this one. If you're shot in the brainstem, a while is not a good term to use for how long the heart keeps beating. I'm sorry. It's just, that's not a really good term for an expert to use. Be more specific, dude. sorry. That's the nurse editorializing. But really, that's an odd word to use about that.
One of that would be respiration, of course. You know, the heart needs oxygen too, so.
Okay, the heart, how does it work if it doesn't have a connection to the brain? In other words, what's the process there that allows that heart to keep going?
Well, the heart has its own internal inherent pacemakers. It will beat and be productively fulfilling its pump function regardless of what's attached to it. Now, the brain connections, neural connections to the heart can raise the speed of the heart somewhat or slow it down and occasionally stop it. But the heart will usually start beating on its own. And witness the people that have heart transplants. The heart, they may end up with a pacemaker to help control it somewhat, but that heart will beat essentially no matter what.
Okay. Dr. Lietzma, with this particular injury that Ms. Clarkson had, would it be inconsistent for her head to move in one direction or the other?
No, it wouldn't. It'd be very hard to know what the precise position of the head was in at the time of the entrance of the bullet. There can be reflex movements or physical forces that might move the head, and so the position that it might come to rest in doesn't really tell you very much about what position it was at the critical moment.
Okay, when you say the critical moment, what do you mean by that?
When the passage of the bullet or the entrance of this and the damage that was caused.
At the time that the shot was fired?
Exactly.
Okay. Dr. Lietzma, have there been documented cases where people engage in these reflex movements when they've shot themselves? Is that something that's in the medical that you're aware of?
Yes.
Okay, what type of materials are you aware of in that regard?
Well, it's never pleasant to talk about, but there have been individuals who have arranged in one way or another, wittingly or not, to be filmed or televised during a suicide.
Okay.
And these exist in the forensic community. I've seen a number of these over the years, usually in the context of a professional meeting where these subjects would be talked about. And of course, they provide answers to the questions that you're posing here, and that's of forensic importance. And so these have more than personal interest involved, that they provide information so that we can answer some of these questions.
Okay. And these incidents over time have been collected like yourself would go to?
Right. I mean, there would be, the interested parties might be wound ballistic folks, biomechanical people, forensic pathologists certainly, maybe a few neuropathologists here and there. But the point is, how does this work? What happens? What can we learn about these?
I still say I'm flabbergasted that anybody would film it. I mean, I guess if you would want, I don't know. I was going to say, I guess if you would want your family to know that you did it, because a lot of people are like, oh no, my family member would never do that. Other than that, I don't know why you would record yourself doing that. That would be a horrible thing to do to your family, though. I mean, a note is bad enough. But I don't care how down or depressed she was about anything. I'm not buying that you go to for a short time. A short time. That's still relative, though. What's short to you might not be short to me. This is also coming from a person with ADHD that doesn't It doesn't understand time. A very short while though, if you get shot in the brainstem. But I still don't think you're going to go to someone's house that you just met and you're going to, excuse me, and you're going to go around their house and open up their drawers to look for a pew-pew? So you can do that to yourself? That doesn't make sense. It just doesn't. And they actually expect people to believe that that's what happened. It doesn't make sense. And they, I guess, apparently on this jury, they got some people to believe it because it was a hung jury. I don't get it. Who does that? I mean, come on. And according to her commercial agent or whatever his title was, she had jobs coming up. Like, if she was so depressed about her career that she did that, it makes no sense because she had things in the works that she was excited for. So it doesn't make any sense. It just make sense.
Okay, so these documented cases, we'll use that term for referring to them, that have been collected and presented to professionals like yourself. What have you as a professional learned from them over the years?
Well, there are certainly instances.
Was it like a close-up of her face or something? Like more graphic than what they've shown in the trial? Because all I've seen are the pictures that they've shown in the trial. Like, there haven't been any close-ups of her face or anything like that. It's basically just been, like, the way she's positioned in the chair. Yeah, I don't want to see a close-up. Because that's got to be awful. Awful, awful.
In which gunshots to the head, suicidally or otherwise, result in immediate.
It's irrelevant unless they're talking about seeing this kind of spinal transection.
All right, the objection is sustained. You may proceed. Okay.
So what do these filmed events show? What do they actually show?
It's the same question.
As to what they show, it's irrelevant. As to what he's learned from them, that's something else.
Let me ask you this, Dr. Lietzma. What do these filmed incidences of suicides show that are relevant to this particular case that you've learned as it relates to the issues in this case?
That there can be a variety of movements, agonal movements. By that I mean dying movements.
I have to object unless the doctor is talking about a complete spinal transection like the one we have here. This is vague, and if it's talking about a shot to the temple, that's completely irrelevant.
Cross-examine. He's possibly can cross-examine him whether it makes his opinion the weight that the jury should give to it. The objection is overruled. You may proceed.
Yeah, but, there's a variety of. Hardly any one of these is exactly the same, but that there are certain movements of the body that can be after a gunshot wound to the head that
There's a variety of different damages to the nervous system, including
the lower center that can produce or permit movements, agonal movements.
Okay. Now, in Ms. Clarkson's case, when the shot was fired, she, in essence, her brain was not able to function as it relates to her body. Is that correct?
Yes.
And is that similar to what happens when somebody shoots themselves in the head when they give themselves a massive brain injury?
To a large degree, yes. You've, in a sense, disconnected the brain from the rest of the nervous system, and what you see is kind of what's left over.
Okay, so basically there's no volitional movement when the spinal cord is transected, when the brain's not working, correct?
Correct.
And everything else is, all of these movements are just reflexive that occur as it relates to the spinal cord and the nerves and so forth that are still functioning, correct, for a period of time?
That's right. There's no volitional, conscious, whatever words you wish to use to describe that. It's an automatic reflex. Whatever movements there are of that character.
Okay. And is it, in looking at Ms. Clarkson's case, is there any way to say exactly what happened in this particular case, since we don't have a record of it?
No. We can only go back to the anatomy, the physiology, and experience in other circumstances to say these things are possible.
Okay. Now, when you saw the picture of Ms. Clarkson in the chair, do you see how she's sort of slumping in the chair? What process is going on there when you see this relaxation process occurring?
Well, as I've indicated, there could be this reflex, which is an extension of the legs and arms and arching of the back, which, if you're seated, as I am in this chair, could get you into a position like that.
Okay. Then what happens after that is, I guess, my question.
Well, then the body comes to rest, usually having no more significant movements like that. There might be some twitching or something, but that's about it. Things become static. That doesn't mean there couldn't be other reflexes of a more subtle character that are operating.
Okay. All right. So eventually then the body just comes to rest in the position after this reflexive movement, correct?
Yes.
Okay. Now, let's talk about those other movements, the subtle movements that you talked about. I take it that if the spinal cord was cut, such as the injury that was suffered by Ms. Clarkson from the shot, any volitional breathing or bringing in air or pushing out air was not going to happen. Is that correct?
That's over.
That's done.
That cannot happen.
Okay, and why is that? If you could explain sort of the physiology with breathing, similar to what you did with movement.
Basically, the mechanism that our bodies have for breathing is, to a large degree, run by groups of nerve cells in the brainstem, that is, in the pons, midbrain, and upper cervical cord. Now, true, we can influence that by, we don't have to think about those things. There are signals that come from our body that say you need more air, and we don't have to think about it. It just happens. The brainstem responds to do that. Now, when you, I should say, the elements of respiration, the chief one is your diaphragm, which is the muscular dome-shaped structure between your thorax and abdomen inside your body. That is the main muscle and action that produces inspiration. To a large degree, breathing out it doesn't have to be a passive exercise. We certainly can force it, but to a large degree, that's passive, a relaxing movement, and we breathe out. The diaphragm is controlled by motor neurons in the high cervical spinal cord from the third through the fifth cervical segment, primarily the fourth. And that's where the nerve cells are that give rise to a nerve called the phrenic nerve, P-H-R-E-N-I-C, that goes down and innervates the diaphragm. With an injury such as happened in this particular case, that function would be lost.
Immediately?
Yes.
Okay. And so because the connection basically is severed, correct?
That's right.
Okay. Now, you use the word inspiration. What do you mean by that?
That means breathing in.
Okay. And is there a word for when you breathe out?
Expiration.
Okay, inspiration, expiration, okay. And would it be correct, Dr. Lietzma, that as far as the normal breathing process, that once an injury like Ms. Clarkson's suffered here in this case, that the normal breathing would cease immediately?
That's right. Yep, that would cease.
Okay, and does that mean that there could be no inspiration or expiration of air in and out of her lungs?
No.
Okay, so that could still go on, and explain to the jury how that goes on, even though this connection's been broken.
Well, it's not going to be like what we normally would think of as breathing, a nice breath and expiring and so forth and so on. What could be possible, because there are other muscles that are involved in both breathing in and to a greater degree breathing out. And these would be the muscles that exist between our ribs, these so-called muscles. There are sets of these. The so-called external intercostals have a certain arrangement that enables them to lift and elevate the rib cage in response to impulses from the spinal cord. So therefore, the spinal cord is intact, these nerves are intact, the control is gone, but they can respond to a stimulus or whatever to trigger a small amount, exactly, I don't know how much, but some degree of inspiration or breathing in. When it comes to breathing out, there's an internal set of intercostal muscles that go a different direction that can contract and squeeze the chest, forcing air out. We mustn't also forget about our abdominal muscles, our abs, if you will, which are also connected to the spinal cord. And if they contract, along with the internal intercostal muscles, the force that could be delivered to breathe out is probably much greater than it is to breathe in. So those things are possible.
And so all the wiring is still connected for those muscles to still function the way you just described?
Correct.
And in this particular case, did you look at the autopsy findings as to the lungs and whether or not there was blood in the lungs and things of that nature?
I did.
And was there some blood that was seen in the lungs?
Yes, there was blood found in the main air passages, and then when microscopic slides came back, there were red blood cells in the air sacs or alveoli. That's where the gas transfer occurs, way out in the lungs.
Mr. Jackson refers to those as the grapes, and he has a little diagram of that. Right. That's the end part of the lungs?
That's right.
Okay, and can that blood get there without some type of inhalation or exhalation?
Probably not. I think you could certainly fill the airway and the major bronchial passages with blood or other fluid, and it might or might not be able to actually reach the air sacs. I think the general view is that's pretty hard to do without some inspiratory or breathing in effort, whatever it may be.
Okay. Does that suggest to you that in Lana Clarkson's case there was some inspiration, expiration events going on?
Yeah, it does.
And that would be after the shot was fired?
Yes.
Okay. And is there when something gets into your airway, blood or whatever, does that have any type of effect on the airway?
Yes, it does.
What type of an effect does that have?
Well, we know from ourselves that if you are swallowing something, you get it down, quote, the wrong throat, boy, the reaction is instantaneous. You can't help yourself. You cough. Now, how much of that is mediated by levels that are below your brainstem, so to speak, I don't know, because we do have brainstem function that causes you to gag and cough and so forth and so on. But the passage of materials that aren't supposed to be there into the bronchial tree incites a sensory impulse there. Mm-hmm. And that impulse will be transmitted to the spinal cord locally.
even though there's a disconnection, it won't go to the brain.
Right. This is a local circuit.
Okay.
And it could trigger a motor response, which would be protective. You don't try to get it out of there. I mean, this is a basic animal kind of response. How forceful or efficient it would be, I don't know.
Okay. In looking at the circumstances of this particular case, could there have been, following Ms. Clarkson's spinal cord injury from this gunshot, involuntary expulsive actions caused by these nerves firing?
Yes.
Okay, and could she have expelled air from her lungs as a result of that?
Well, it'd be, yes, the answer is yes.
How would you describe how that would work? If you could actually maybe visualize it like is it a, or what would you characterize?
Well, I think there's two components here.
Okay.
One of them is with the gases and the pressure that come from the explosion of the cartridge and entering of that material into the oral cavity. There's a lot of pressure there, and it will distend the cheeks and face, and gas has got to go somewhere. And if there's any place where gas can go and be compressed to an area of lesser pressure, it's going to go there through the nasal cavity, to the esophagus, to the air passages to the lungs. So they're most likely for an instant is high pressure, let me just say air. The gas is in the product of combustion and air also, but there's gas that is there. And gas could most likely enter the lungs as well and distend the lungs. So when the pressure is off after the, milliseconds later or whatever after this bullet is finished, that's got to go somewhere. So there is a blowback, in a sense, of gases that are in various places, and the most logical place for that to go is out the mouth. So that to a large degree, I would say, is passive and would result in just simply elastic compression or release of the chest and so forth. The second component could have a reflex part to it, which involves triggering all of these remaining chest muscle reactions as well as the abdomen, which could react in kind of almost like a vomiting sort of reflex. It's not the same, but or a coughing kind of situation where there is a forceful additional expulsion of air, gas, and whatever might be in it out of the mouth. Probably that's a one-time event.
So this is secondary to the initial explosion.
Right.
Coming out, this would be secondary as a result of the connections to these muscles and so forth.
Exactly. Whether it's exactly congruent in time or separated a little tiny bit, I don't know.
Okay, and could this occur for a number of seconds afterwards?
I don't know that it would be a number of seconds. I would say this would be a 1-2 type situation if there were any difference between the time events. Something like that could happen later. I mean, the muscles are there. They could potentially spasm and do this a second time. There's no way I can know.
You can't predict it in this particular case, is that correct?
No.
But the muscles have that capability, is that true?
Right.
And do you use the word shuddering or some other type of word to describe this?
Well, there could be, following this initial catastrophic event, there could be some, because there's irritation undoubtedly in the bronchial tree, there could be some kind of stuttering or shuddering or there's lots of words that you could, panting or some kind of respiratory effort that could include a little bit of inspiration and expiration. It could be kind of like an accordion where they want to make a bunch of fast notes, but they don't expand the accordion very much.
Okay.
I would characterize the probability of that is like that.
Okay. Explaining it like an accordion going in and out real quick. Is that
Right.
basically what you're saying, Doctor?
Yeah, or certainly not big movements, but it could be a twitching, fluttering, shuddering type of movement, which may or may not last very long, and then would pass away.
Eventually, there'd be total death and all cessation, correct?
Yes.
Now, Dr. Lietzma, would that type of shuddering, could that account for this blood getting into these air sacs that were actually seen in this particular case?
It certainly could. I mean, given the fact that it's very likely that there has to be some sort of inspiratory breathing in effort, however unconscious, some negative pressure someplace to allow this material to be pulled deeper into the lungs, I think it's inescapable. I can think of no really rational, better explanation for it.
Okay, and so the blood got there some way, and the blood got there because there had to be some inhalation type movement to get the blood to these air sacs, correct?
That's my opinion, yeah.
And if it got there, then it had to leave also, is that true?
That's true, and in terms of the expiratory effort, that's a little easier anatomically and physiologically to put together, so to speak, to understand.
Okay, and when the expiration part of that equation occurs, it has to be either the mouth or the nose, is that correct?
Yep.
Okay, and if there was blood in the mouth or the nose, then that blood could get expirated out also, is that correct?
Especially if in the first or second, if there were two major twitches, I guess, or spasms, yeah. And then, of course, you still have the exodus of the gas by pressure passive movements or phenomena that can carry material out, too.
Mm-hmm. Okay. Very good, Doctor. If I could just have a minute here. Let me ask you this question, Dr. Lietzma. You're not, you being a neuropathologist, do you know anything about how far this material goes, or is that something outside of your field?
I've certainly seen some of this material, read some of the things, but I would say that that's at the edge of my expertise. I wouldn't have any special knowledge that would help us to do much with that.
Okay, that would be in the field of a blood spatter expert?
Yeah, or forensic pathologists that have spent some time studying this or have some special knowledge or expertise there.
Okay, but you can tell us, and you can tell the jury, that this process of involuntary inhalation and exhalation can occur after the shot was fired for a short period of time, correct?
Correct, that's what I've done.
And it's impossible to say whether it was 5 seconds, 1 second, or more in this case, because we just simply don't have a record of it.
I wouldn't know how to come up with a number that would be logical. I think it's probably for a short period of time, but what that time period is, I don't know.
Okay. Now, the finding that there was blood in the air sacs, how was that documented by Dr. Pena in the autopsy?
First of all, you probably wouldn't see it with your naked eye. He made microscopic tissue slides that he looks at under a microscope. And it's my understanding that it was reported that there was blood in the alveolar air sacs upon that examination.
Okay. Now, you also, just to pick up this one final area, then I think I'm done, you talked about the air going into the lungs at the time that the weapon is discharged, the gun is discharged.
Right.
Did you see evidence of that in the autopsy, damage that gets...
Yes.
Okay, what did you see, if you could explain that to the jury?
There's, beginning at the upper end, there's photographs of the oral cavity showing many streak-like bruises and submucosal hemorrhages that would be quite typical for a distension over inflation kind of scenario.
Okay.
Furthermore, there's similar injuries to the back of the throat, base of the tongue, and upper oropharynx.
When you say similar injuries, are you talking about bruises that are down in the throat area?
Bruises of the tissues of the throat area that would be certainly typical for a sudden expansion, overstretching, so to speak, not penetration by some physical object, I would say tearing or over distension, which would be typical for the kind of thing that would happen when you have discharge of a firearm in the mouth.
Okay. Did you say anything as far as the injuries or photographic documentation of the mouth at autopsy that was inconsistent with a firearm being shot inside the mouth?
No.
Okay. I take it that's something that pathologists have seen in the past. Is that correct?
Yes.
Okay. And the bruising that you talked about, setting aside, let's say, the tongue and the cheeks and the inner mucosa that you talked about, was there bruising actually down into what we call the throat or airway?
Yes.
Okay. And was this bruising caused by this explosion of these gases?
In my opinion, yes.
Okay. Is there anything else to account for all this bruising down in the throat and the airway other than the gases?
I can't think of one.
Okay, it wasn't that the bullet went there, correct?
Well, we can certainly see the penetrative forces of the bullet and whatever fragmentation occurred. Yes, that's a totally separate.
That's a separate wound.
Exactly.
These other bruises down in the airway and the throat were because of this explosion essentially occurring.
I believe so.
Okay. And this bruising would have occurred because the heart was still going and the blood vessels were broken and the blood basically leaked out as a result of them being damaged.
True.
Okay. Very good. Thank you, Dr. Leitzman. Nothing further.
All right, thank you, ladies and gentlemen. Keeping in mind the admonition, we'll take a 15-minute recess at this time. Thank you.
Cross-examination, and I hope it's Jackson. I think it's Jackson, but I don't know for sure. Yay, it's Jackson. Damn it. Stupid StreamYard. Hang on. I gotta share my screen again. It knocked my audio out. StreamYard hates me. And I hate it right back. As my husband would say. Anytime I say something hurts, or I hate something. If something hurts, he says hurt it back. And if I hate something, he says hate it back. So I hate StreamYard right back. Right back at you, StreamYard.
Boom.
Well, let me see. Probably about...
Straighten up and fly right. That one was my daddy's. Gonna bust out all the southern idioms before this is over.
I hadn't expected that and was contacted in the midst of some travels and so forth, so I can't give you the exact time.
Had you been following this case at all?
Essentially, I mean, I'm aware that the case existed, and frankly, 2 weeks ago, if you'd asked me what the situation would be, I'd say I don't know whether the trial is over or whatever.
Did one of the defense other experts contact you, or was it one of the lawyers?
I've had contact with one other, I presume will be called Dr. Bodden.
That's Dr. Michael Bodden?
Yes.
Okay.
Oh, yes, and I have to say, I did have a conversation with Dr. Werner Spitz, too.
And that was after Dr. Spitz's testimony in this case?
I don't know if he had completed his testimony or not. I don't know.
And then ultimately, you were contacted by one of the defense attorneys?
That's correct. I'd received a telephone call from conversations with some of the other counsels.
Is that Linda Kinney Bodden?
Yes, correct.
And your other consultation was with, I'm presuming, Chris Plord?
Yes, I have.
how many conversations would you estimate you've had either with Miss Kinney Bodden or Mr. Plord in total?
There were a bunch of emails.
Do you have any of those emails?
Well, let's see, until I got here, I hadn't seen any of these people in person.
Okay.
Had telephone calls and emails.
Was there any, on that question, was there any discussion about your potential testimony in any of the emails that you received?
Oh, I'm sure. I mean, they said, well, we may need to call you at this time, and I said, well, I'm not available, or I'm traveling, or doing something. I'm doing a mechanical kind of business.
Right. Was there any, I guess what I'm asking is, I don't care about travel arrangements necessarily.
Yeah.
That's none of my business. I'm just curious as to whether or not there was any discussion about your potential testimony. We might need you to testify to this fact. These facts were brought up in court. We're either not satisfied or we're satisfied. We want to bolster it, et cetera.
I think the emails were purely, business arrangements and, by travel and scheduling and so forth. And we did have some more conversations by telephone that elements of the case, because obviously I had some questions about, well, what's available, what are these here?
Did you make any notes about those conversations? There was no notes at all, or not jotting down notes to yourself about, look, if these issues are going to be addressed, Mr. Porter, we're going to bring this up. Are you aware of when the prosecution was notified about the defense's intention to call you?
I'm sorry, I missed that question.
I'm sorry, what was the question again?
Whether or not Dr. Lietzma is aware when we were and told that
I don't think it's necessary. We can do it some other way.
I'll ask, when was the first time I ever had an opportunity to visit?
Not
To introduce myself. All right, yesterday at 3 o'clock was the first time you and I ever had a conversation about your potential testimony.
That's correct.
But you had certain conversations with Mr. Plord and Ms. Kinney Bodden previous to that conversation.
Sure,
and Mr.
of course.
Plord was in the room when you and I talked yesterday.
He was, yes.
Mr. Jackson?
I realized I did it as soon as I said it. I was stepping on your
If
words.
you can
And I
just
know I was about to get slapped for it. So
Just slow down a little bit, thank you.
sorry. I was trying to sneak through that point and see if I could slow down myself. All right. There was one thing that I wanted to clear up before we actually get to the content of the 2 or 3 points, and there's just 2 or 3 points that I want to raise with you, Dr. Lietzma. Mr. Plord raised some questions about some videos and demonstrations that in the medical community you might have seen or might have been shown at a paper that was given or a talk that was given or a seminar. And he asked you specifically about videos of suicides. You recall that conversation?
I do recall that, yeah.
The fact of the mouth and the physiology of that gunshot wound to the mouth, it doesn't make any difference if it was self-inflicted or if it was a homicide and somebody else's hand was on the gun, correct?
As you state that, that's correct.
I mean, you're not here to testify that this was a homicide or suicide, physiological things. Pathology, conferences, etc. There's been tons of videos of homicides as well, security videos.
There have been some, yes, that's true.
But Mr. Plord didn't ask you about those.
No.
All right. And in fact, I guess I should say this. I asked you this yesterday, I think, in our phone conversation. Not one of those videos, nothing that you've seen live has ever indicated the exact same injuries that we have in this case.
I don't believe so. To duplicate this case, I couldn't say that I've seen one like that.
And when we say like that, just so the jury's on the same page as us, we're talking about a complete transection of the spine through a gunshot wound.
In many of these videos and things that I've seen, it's been a variable amount of autopsy material that accompanied that. So sometimes I wouldn't know what it was. It was simply talking about the injections of the spinal cord or not. I don't recall any one of those having that.
All right. So this case, insofar as that is concerned, this case is somewhat unique here.
In terms of dual experience with an event like this, that would be phenomenal.
The point that were raised on direct examination, that was the example that you gave with the frog, correct?
Yes.
All right. That is, as you termed it, I think you said posturing, sometimes it's called, correct?
That's right.
All right. I want to talk about the timeline that we're discussing here. When you talk about, and by the way, Doctor, you're not saying decerebrate rigidity.
I don't know.
Okay.
I'm just saying, if someone has questions about that, I can say whether it
timeline of this phenomenon known as decerebrate rigidity. You're talking about it happening basically at the instant of the transection of the spine, at the moment of the gunshot wound, correct?
Well, we're talking about, and then there may be some things that trail on, which I'm sure we'll get to, but
Sure.
Basically, instant means, right then. I don't know that. I mean, it could be 100 milliseconds later or 0.2 of a second later or something. There's no way I can know that.
As far as, and I understand I may have been a little inartful with my question, as far as lay people are concerned, when I slap my hand down and you hear it, there could be a scientific argument that you hearing it didn't occur at the same
See? 0.2 of a second. A while. 0.2 of a second. That was my point.
time that I slapped this,
Exactly.
correct? That's not what I'm talking about. I'm talking about the gunshot wound, boom, the rigidity. It's basically instantaneous. We're talking about milliseconds, correct?
It would be something,
Okay, so within a second.
certainly.
May the record reflect that the witness, I guess in an echo of my pounding on the table, he indicated with his left and right hand maybe a half a second between two slaps on the table.
It's going to be in that domain. I mean, it might be a little more, might be a little less. I don't know.
His was more restrained than yours.
Can we take a look, see, with your permission, at People's 29? I'm going to ask you to take another look at a photograph similar to the one that you saw just a few minutes ago. This is a photograph of Ms. Clarkson that's been marked as People's 29 and entered into evidence. I want you to focus on her legs. Do you see how her legs are positioned in this particular photograph?
Yes?
All right. And you indicated, in terms of your opinion, one of the possibilities that you opined about is if a person was seated upright as you were seated in the witness chair with their feet flat on the floor, that there is a phenomenon known as decerebrate rigidity, which could extend the legs out in front, correct?
Correct.
And that's the momentary, sorry, that's the slight delay. Well, how do I want to put this? I can't think of a better word than almost instantaneous, but for purposes of our discussion, let's just use that word because I can't think of a better word for it, Doctor. That would have happened, any extension of the legs would have happened basically at the time or at the point of the gunshot wound, correct?
It would be very proximate to it. I don't think it occurs at exactly that instant, but in the immediate second or two afterwards,
Okay.
That event, that posturing could occur.
Okay, and of course, anything let's assume, for purposes of our discussion, that the legs went from this position, and I've got my legs basically straight down, and now I'm putting them out in front of me just a bit. Let's assume that they went from position A,
Yep.
down on the floor, to position B with my heels basically resting on the floor. That doesn't move my thighs.
Well, that would be part of it. There's usually other components to this decerebrate rigidity, which involves arching of the spine.
Okay.
And that, obviously, the rear end is not back in the chair here. It's out somewhat forward. That's why I say that this general attitude of the body could be explained by an episode of decerebrate rigidity after the gunshot wound.
But back to my question, I guess, explain this relative position of her thighs.
Oh, I think it,
Well, he's asking for cross-examination, so it's a cross-examination question. The objection is overruled.
I think it would, because if one slides forward, obviously the angle and position of the thighs are going to follow that of the lower extremities, below the knees. So I think it would all be part compound, and to try to dissect all of that is really, it starts getting close to speculation, which I cannot and shouldn't get into. Yeah, we don't want to go there.
All right. Let me ask it this way. The way her thighs are positioned right now in that photograph, her thighs are exposed to the open air above her.
Sure looks that way.
Okay. Even with the phenomenon that you described, decerebrate rigidity that may have occurred, her thighs would still have been exposed to the open air above her. I mean, we're not talking about her bending her thighs underneath her as I'm sitting on the edge of the chair, correct? See how I'm sitting with my thighs at a severe from this angle to this angle.
Yeah, in terms of exposure of the thighs, of course, we're talking about then this dress or slip or whatever it is, this garment that she's got on. That, of course, might have a different gripping with the seat, such that the body could move forward and this would, in effect, raise the skirt. But in terms of the position of the thighs, they're exposed. I mean,
they're exposed.
I don't see how that's going to change much.
That's my question. All right. And the other thing I wanted to ask about her position, Doctor, is the other way. And you said this is one possibility. You talked to Mr. Plura, this decerebrate rigidity happened. And you said, I don't know if it happened.
That's right.
The other is basically in this position that I'm in now, leaning back in the chair, at the time the gunshot was fired.
I couldn't rule that out.
Okay.
Stupid StreamYard. Can y'all hear me? I am not in the mood for this. Knock it off.
Bullet through the back of the throat, transecting the spine, a traumatic wound to the back of the throat. There's going to be a substantial neck area, correct?
there will be bleeding. How much of it finds its way out into the environment? I would say probably, given this, the way where blood can drain, probably a lot more internally than externally. But some will come.
That it would bleed down the back of the throat.
Right.
More prevalent.
It's just
The evidence indicated, doctor, that she had substantial blood and tissue flow down the right side of her lapel on her arm, onto the arm of the chair, and to the other side, and that blood flow on her right side.
Okay.
Would that indicate to you that, in fact, her head was lolled to the right after the gunshot, and therefore bleeding on her right side?
Vegas at times after the gunshot.
Well, I think are you referring to right after the gunshot wound?
Correct.
Okay, then
I'm not sure what that means as far as Vegas.
the objection is overruled. You may answer the question.
I mean, the conclusions you're drawing that gravity is there, and you have to look at that. And if you have a certain blood flow pattern that seems to obey the laws of gravity, so be it. Whether the head is moved in some way, voluntarily or by somebody, I have no way.
If the evidence suggested there was enough blood flow on the side to basically get all the way down her lapel, onto her arm, arm of the chair, down into her purse, and then puddle on the floor beneath her purse, literally pooling from the purse and
No, it was StreamYard again, being stupid. Being stupid. Stupid, as usual.
dripping through the purse to the floor. And there was no blood flow on the left. Is it your opinion that after the gunshot and after her spine was transected, that she could have bled that much to the right and through the cerebral rigidity, her head to the left?
First of all, time probably would have to give you vague answers because that's all I'm capable of with that.
Sure.
It does take time, and if the head is in a different position when the photographs are taken, something move the head. Whether it's the
I don't understand why they're going over the mechanism part of her death. I don't know if I said that right. Like her head moving and the way she was sitting in the chair, and like I understood when they were doing like the back spatter part about the blood being on him or being on her, or like the pattern of the blood on the back of her hands, that kind of stuff. Like that made sense. I got that. Well, StreamYard, what are you doing now? Thank you. But some of the mechanisms that he's talking about, like the way her head was moved or the way she was sitting in the chair, how is that going to be any different whether he did it to her or she did it to herself? Is it going to be such a huge difference that it's going to be able to tell whether he did it or she did it? Or is it going to be the same regardless? Because if it's going to be the same regardless, then why are we wasting our time talking about it? You know what I mean? I just don't see a huge difference in the way she would be positioned in the chair after the shot, whether he did it or she did it. You know, it just doesn't seem like some of this stuff has to the wrong, unless I'm just not understanding the reason why they're talking about such things. It just seems like some of the things wouldn't matter. It'd be the same either way. Unless I'm just not comprehending. I don't know. You guys let me know what you think. I just think she would still end up in the same position in the chair no matter who did it. I just think they're going too in depth about some of the things that would have happened either way it was done. So, I mean, not that we're wasting time or anything. I guess we're being extra thorough, but I just don't see how there would be any difference.
Or movement of somebody else, or just reflex, or who knows what.
Well, my question is this. You just said that it takes time for all that blood flow to on the right.
Right.
Give me an idea.
Experiments with her. If you're talking about blood reaching the floor, many seconds, maybe even minutes. I don't know.
Several minutes, probably.
I don't know. I wouldn't want to go any further with that because simply I'd be guessing, and I don't want to do that.
Let's assume that the blood is draining out of the head to a point that you'd be comfortable saying, for purposes of my hypothetical, that you'd be comfortable saying it took several minutes to...
Right? Seriously. And we were wondering about that forever. Like, what difference does it make? And now we're talking about the position she was in the chair, which to me makes no difference at all. It's kind of like, see, now I'm curious. Like, I want to watch the second trial to see if they streamlined it like they did with the Karen Reed trial. Because the first trial was so intricate. Like, everybody that was at the bar that night. Lally brought in everybody and everybody that was at the party. Everybody. And then Hank Brennan came in and streamlined it. And I'm just wondering if the same thing happened in this second trial. Because they're talking about every teeny tiny thing, and every friend she ever had has come and talked about her. I mean, this has been one weird trial. They don't do trials like this anymore. Well, I guess I shouldn't say that because the first Karen Reed trial was last year, and it was weird like this too. So, yeah, like the Karen Reed trial is going to be one of those things like, 20, 30 years from now, people are going to be going, do you remember that trial? That was a crazy trial. And I'm going to be like, yep, I was right there covering it. I was there every day. Come on, StreamYard. Can you play nice? Please, can you play nice? Pretty please. I let you have a day to rest. I gave you a day off.
And that took several minutes. Decerebrate rigidity would not ever, in any way, shape, form, or fashion, move her head to the left.
At times from now, how the head came to be in a different attitude, I have no idea.
All right, Dr.
I don't know.
Let me repeat my question. All I'm asking you is, and I think we understand that you're not guessing. It took several minutes of the the head being on the right side, several minutes passage is not going to, decerebrate rigidity is not going to account for her moving her head.
I would not think that's far more proximate to the injury.
As a matter of fact, you described the decerebrate rigidity happening.
Well, I can't put your comment on the screen, Judy, but you said in the photo I saw, there really didn't seem like there was much red stuff. There was some, but it didn't appear to have run down and pooled. I would think that makes sense because she's sitting. Oh, this is too graphic for me to say. She's sitting, and where the gunshot wound is, gravity. Oh, I can't even say this on YouTube. Use your imaginations. But yeah, I wouldn't expect there to be a whole lot of blood pooled around her.
About like,
Well, it probably wouldn't do that. I suppose the reflex could occur, I would say, within some seconds. I doubt when you start getting out minutes that it would occur at that length of time, but again, I don't know.
Dr. Leitsma, didn't you just testify that the decerebrate rigidity that you were talking about was like this?
I don't believe I testified to that. I said that there can be reflexes that occur, not necessarily decerebrate rigidity, because I don't want to give the impression that that's a lightning reflex. It's really sort of as I've demonstrated, takes some time to occur. And whether that would occur within a fraction of a second after the injury or in the immediate several seconds afterwards, I can't say.
Then what did you mean by this?
And for the record like this, it's a 1-2 count of tapping on the podium.
We're talking about the first impact, the first sound being the passage of the bullet. The second might be the expulsive forces of the chest and the passage of gas out of the mouth. In terms of the reflex rigidity and so forth and so on, if I gave the impression it occurred that quickly, that's incorrect. It does take a little period of time to do that.
You didn't give the impression. You just testified under oath that's what it was. I mean, we can have the record read back if you need to.
We may need to do that. I certainly do not want to give the impression that decerebrate rigidity had to occur 1-2 like that. My judgment on this matter is that this could occur in the immediate seconds after the gunshot wound, that there are other things that certainly do occur 1-2 like that. And
Doctor,
I wouldn't include decerebrate rigidity in that.
You wouldn't include that?
I would not.
So if you said that, if I asked you when I first stood up here to give me a timeline for when this decerebrate rigidity takes place, whether or not it was instantaneous, if I asked you that question and you said it would take place within milliseconds or say a half a second of the gunshot wound event, then that would have been a mistake on your part. That would have been incorrect.
If those statements you just made are true, that would be incorrect. I like a longer time frame between that. There are other events that certainly do occur 1-2.
So you're now saying that 1-2 was not talking about decerebrate rigidity.
No.
What were you talking about, Doctor?
I don't know. I'm not memorizing everything I say. What I am talking about, that I think in terms of an immediacy like that, would be the expulsion of the gas, the reflex the spasm of the chest and abdomen. Those things would occur in that sort of time frame.
And you do recall just a second ago when I stood up and started asking you questions I didn't say a word about reflex actions of gases. I didn't say a word about reflex actions of the abdomen. I asked you specifically about decerebrate rigidity.
And I've attempted to answer that, saying that I don't believe that I answered indicating that the decerebrate rigidity would occur that quickly. And if I gave that impression or I said that, that is not correct.
Are there any other mistakes that you've made in your testimony thus far, Doctor?
I don't know. I assume you'll point them out.
The spasm or tremor that you're describing, and I'm just using those words because I don't have a better word for it. The rigidity that you're talking about, are you a phenomenon where all arms and legs just do this? And I've indicated, Your Honor, for the record, my arms basically straight out, parallel to the ground, rigid in fashion.
No.
Small.
No.
What kind of spasm tremor are we talking about when it does occur?
A typical form of decerebrate rigidity is with the legs going straight out the arch, the spine arching, the hands in an attitude of extension and the head in an attitude of extension.
All right.
And it doesn't happen like that. It evolves over a second or two.
Okay, like that was a click of the fingers.
So now what you're saying, so we're clear. Now you're saying that it occurs within a second or two of the injury.
It could occur later, but yeah, that's about the earliest that I would expect it to occur.
Well, doctor, help me out. Now you just said a second or two, and I asked you to confirm that you said a second or two, and now it turns into, well, it could be later. Give me the time for decerebrate rigidity. You're the neuropathologist.
I cannot give you the time, and it was my remembrance that I indicated. I doubt that it happens at the instant because it takes, there are some things that have to happen to allow that to occur. And over a period of perhaps several seconds after the event, decerebrate rigidity can kick in.
Okay.
And that I don't know precisely when that happened, and there is a time frame, a bell-shaped curve, when that can occur.
How many is several seconds now?
Pardon me?
How many is several seconds?
I don't know, 3, 4, 5,
Okay.
something like that.
Let me make sure I've got a second hand on my watch.
Right?
Give me 1 second, okay? Gunshot. All right, what I've just
Yeah,
done.
that's 5
hang on.
seconds, right?
What I've done, for the record, Your Honor, I stopped my hand on the podium to indicate the gunshot. I said the word gunshot. I waited 5 seconds.
Right.
And I extended my arms in front of me. Is that what you're saying?
I'm saying it occurred within that, probably within that period of time.
I got to finish my question. I'm sorry, otherwise the record will kind of be a mess. Are you testifying that that is consistent with what you understand to be decerebrate rigidity and that phenomenon when it does occur? It occurs that long after the fatal shot.
No, it can be that long. I'm not saying it is 5 seconds. It can be within that period of time. This is not something that you push a button and it immediately happens. There can be a delay, but I would say within 5 seconds probably, if we're timing that way, that is when this event occurred.
Doctor, then what were you discussing or what were you explaining to this jury when you said at the beginning of our conversation about this, you used the time frame of 100 milliseconds? What were you describing then?
What I'm talking about at that point is the immediate propulsive effect of gases and other, the chest reflexes, the abdominal reflexes can occur like that. I'm not talking about decerebrate rigidity occurring in that time frame because it takes longer than that to do it.
All right. We're going to move on.
Okay.
Mercifully from this subject.
Well, I think he was just having some fun with the witness. That's the way I interpret it.
That was meant.
It was not derogatory.
No, not at all. It wasn't meant as such. Because, Doctor, it may be my confusion. I mean, it probably is. Normally when I'm confused, Anyway, let's talk about, you just brought up the gases and the expiration of blood. Let's talk about that and change gears just a little bit.
Okay.
Yesterday, you explained this to me on the phone, correct?
I did.
And by the way, let me ask you this. One more question before we move off of the decerebrate rigidity. Yesterday, I asked you to give me the time frame or the timeline for decerebrate rigidity. And yesterday on the phone, isn't it true, in front of Mr. Plord, and I think Jen may have been on the other end of the line as well on a conference call in front of a couple of associates of myself, you indicated that it was basically instantaneous, and you used the word instantaneous. Do you remember that?
You're providing memories that I don't have.
Okay, fair enough.
I don't intend to communicate that, and I don't remember saying that.
Okay, all right. And you don't remember saying that earlier this morning either, to my question?
Instantaneous? No. That if I somehow did that, that's wrong. That's
Okay.
just not correct.
Okay. The expulsion of blood, you indicated that there could be, and again, I think you qualified this, understandably so, you qualified this as saying, I'm not saying it happened in this case, but I'm saying an explanation for the gases or this type of gunshot, the gases being inside the mouth,
Right.
is that the esophagus could have gotten filled all the way down to the lungs, they get filled. The lungs then contract, and out of the lungs up through the esophagus, the diaphragm contracts, and there could be expulsion of something out of the mouth and or nose, correct?
I believe that's fair, yes.
Okay. When does this occur?
Say again?
When does this occur, doctor?
Yes.
This phenomenon, when? Give me the timeline for then.
Oh,
for this.
gosh.
Is this instantaneous with the gunshot?
That's within the fractions of a second. I mean, the discharge of the firearm and the passage of the rise of pressure and the expulsion of gas is in milliseconds.
Okay, so this one is milliseconds.
Yeah,
You're sure about that?
sure.
All right. Couldn't happen 5 seconds later?
On TV, maybe, in these slow motion cuts that they make of bullets going and people getting out of the way, maybe, but not in reality.
Let's do away with Quentin Tarantino and just talk about neuropathology. In your expert opinion, if this phenomenon occurred, this phenomenon would have occurred at the moment of the gunshot.
Within milliseconds of that, that's how it plays itself out, yes.
By the way, do you have, can you point me to any documentation? I'll get to that in just a second, doctor. I don't want to get off the point. I'll lose my train of thought. Would you agree that the best evidence, if there was a phenomenon such as you've described, where there could have been gas expulsion from the mouth or something,
Right.
if there was gas expulsion from the mouth, and let's say it carried with it any blood particulate matter, right? The best evidence of how far that went is where it ended up, correct? Outside the mouth, if it occurred at all.
Yeah, I mean, I don't know how else particulate matter could be transported.
Okay. So the best evidence of how far, you said, I don't want to opine as to how far it goes because I'm not a blood spatter expert, correct?
Correct. I mean, that's outside my areas of expertise.
Right. So the best evidence as a pathologist that you could opine.
His opinions as to how far, he's not giving an opinion on it.
I'm not sure what the entire question is going to be. The objection is premature and overruled. You may proceed.
The best evidence of how far, if it did occur, the best evidence of how far it went is simply where it was found.
Sure.
Okay. And again, this is, you qualified this opinion with the same qualification you qualified the decerebrate rigidity opinion with, and that was, I don't know that it happened. I'm simply opining about a possibility, correct?
Well, in terms of particulate movement and so forth, I'm not making much in the way of an opinion there. I think I'm stating the obvious in terms of the other, that's the context in which I answered the question.
Okay.
That I don't know that it occurred, but here's how it would happen if it did.
Okay. Now I'm going to ask you the question I was going to ask just a second ago. Can you point me to documentation or research or experiments that support your opinion that you just gave here a few minutes ago that the cerebral rigidity can happen up to 5 seconds after a complete transection of the spine?
Sure. The primary source for, this is basic neurology, and virtually every major neurology textbook would have some treatment of this particular subject. Now, they don't become forensic and say how long it happens.
Well, that was my question.
But I'm just saying, where do we get this information from?
My question is...
Well, he hasn't finished his answer. Let him finish his answer, and then see whether it is a direct response. You may finish your answer.
Certainly neurology textbooks, and there are specialty books, one particular by Plum and Posner called The Diagnosis of Stupor and Coma. They deal with these issues in terms of temporal sequence, and I think you have to get into case reports, personal experience, and so forth and so on, which I have, but that's where this comes from.
Okay, I guess my question wasn't, pardon me if I misinterpreted your answer. My question is, documentation, research, or experimentation that indicates the temporal aspect of your testimony. In other words, the time frame, this jury, that it could happen up to 5 seconds after a complete spine. And what I'm asking is, show me the documentation or point me to that documentation that supports that.
Okay. I won't say 5 seconds. It can be longer. There are counts, as gruesome as they are, of guillotine executions during the French Revolution where doctors studied the cadavers of people who'd had their heads cut off and described reflexes that went on sometimes for hours afterwards. So the concept of studying these things has been around for a long time. There's a robust literature on all of this, largely from the, I would say, late 1800s into the middle 1900s of the founders of neurology that dealt with these subjects. In terms of time frames, I don't think they approached it that way, but there could be that information in some of those articles. And then animal experiments as well. I mean...
let's stick with human beings.
Pardon me?
All I'm curious about is human beings. The top level vertebrates, human beings.
Well, I'm saying there are certainly accounts in textbooks, early writings of the people who developed these concepts over the last almost 100 years.
Okay, so if I understand your testimony correct, you're talking about scientists, or, I'm sorry, not scientists, you're talking about accounts dating back to the French Revolution.
Sure.
Where decerebrate rigidity occurs hours after a person's head is chopped off.
They didn't describe it as such. That term came in much later, but in terms of movements of the arms and legs, arching of the back, and so forth, those things were described back in those days.
Hours after the fact.
Pardon me?
Hours after.
Yes, there were some people who were doing this kind of thing, and I don't recall what the terminal time was, but it was an astoundingly long interval, and I recall that it could be hours later.
Do you think that, is there any evidence in this case that Ms. Clarkson, any evidence that you reviewed, that Ms. Clarkson experienced decerebrate rigidity hours after she was shot through the back?
I don't know that she did at all. I'm just saying it could have happened, and here's how it could if it did. And in terms of the time frame, I would have no way to know that, to answer that question.
Okay. Concerning the alveoli, this is the last area that I want to visit with you about. You reviewed the report, the autopsy report, the protocol that indicated that Dr. Pena had made some microscopic slides of areas of the alveoli, yes?
Yeah, he had made some slides of the lungs, and those are the results of that exam were reported there.
And he ended up reporting that there was blood in certain foci, focal areas of the alveoli.
I don't remember the exact words, but they involve blood in the alveolar air sacs.
Okay. The word foci used in that context, or focal used in that context, would mean what?
Well, just as it means, here, there, not everywhere.
There we go. That's actually a very good way to put it. Here, there, not everywhere. In other words,
If you take those words to be representative and correct, that's how I would interpret it.
okay. So in other words, if the back of this represented a slide of an area of the alveoli, foci or focal areas of blood would be a little area here, an area here, an area here, correct?
Maybe even more, but,
Sure.
but not as though you took a paintbrush and covered the whole thing.
Not filling it up.
Exactly.
Okay. So if someone took that, well, I'll just leave it at that. You indicated that there's the reflexive movement that you suggested with Mr. Plord was this shuddering. I think Mr. Plord used the word shuddering.
Yeah.
I want to explore that just a little bit. What you're describing, you're not.
Fair enough.
Are you talking about taking, and what I've done for the record, Your Honor, is I've taken 2 or 3 rather deep breaths and exhalations.
No, that's not what I'm talking about.
Okay. You're talking about tiny, as a matter of fact, I think yesterday you indicated to me on the phone, tiny little breaths.
Little panting. I mean,
Okay.
I don't know how to communicate that.
Sure, it's kind of tough.
Stuttering, spasmodic, twitchy, shallow, probably short, quote, breaths.
Okay, so if and I'm going to step over closer to the jury with the court's permission. I'll turn my head away. If I went like,
Yeah.
that's sort of what you're talking about.
That I can't tell you how deep, but that's of the subtle, relatively subtle thing that I'm talking about.
I have no idea how to describe that for the record.
I don't either. I try to use details.
Well, I would say an exhausted chihuahua, but
If that gets reported as such, I'm never going to hear the end of it.
I'm sorry. I will hear from the chihuahua lobby, no doubt.
What I did, because I had my back turned to certain jurors, I'm just going to repeat what I did, Doctor. What I was doing is like that.
A short panting
short
kind of-
panting like breaths.
Whatever.
Certainly not suggestive of expirating liquid or solid materials out of my mouth.
No.
Okay. So if someone described after death, if they were describing inspiration and expiration as a deep, for instance, and I'll describe that as a raspberry, that would be incorrect.
That would be incorrect, and that sort of breath would mean that the brainstem and spinal cord had been still connected.
All right.
It wouldn't happen.
It would never happen.
I don't believe so.
And any suggestion to that effect would simply be wrong.
Then somebody would have to explain the physiology and anatomy of that, and I'd be interested.
And as a neuropathologist, you certainly would not agree with that.
I don't think so.
Thank you. The other explanation for those foci.
See, this is what I'm talking about. She's not going to be able to do that. No matter who did the thing with the pew-pew, she's not going to be able to do it. Whether she did it or he did it. So why are we talking about it? That's the thing that I'm confused about. Why are we talking about how she was afterwards? Because it's going to be the same whether he did it or she did it. How does this testimony, which I'm not saying it's not important. What I'm saying is, how does this testimony help the jurors figure out who pulled the trigger? And that's what the trial is for. So I'm confused as to why we're hearing this kind of testimony, because it doesn't differ at all. It doesn't matter who pulled the trigger. So that's my point. Like, why are we listening to testimony that doesn't differ from either side of the argument?
The focal areas of blood in the alveoli, the air sacs of the lungs, or what I like to call the grapes. Look like little bunches of grapes. Could be gravity.
Into the major airways.
Like maybe 12 hours?
I don't know anybody who's done experiments like that, but given time, it's conceivable some can find its way out. It's just sort of not my experience like that. Usually when you have stuff in the alveoli, you need something positive. I shouldn't say positive. You need negative. You need a vacuum or something to bring it out to be overcome. So I can't say it could never happen, but it's just that isn't what I would think about or comes to mind.
But certainly if the transected, there's going to be leakage of spinal fluid, which is spinal fluid looks about like this, doesn't it?
Correct.
I mean, it looks like
Clear.
water. It's
water clear.
water clear and not thickly viscous.
Watery.
Okay. That mixed with blood would certainly tend to water down the blood a little bit.
Yeah, how much, but you're not going to have a lot of spinal fluid doing that. And I'm not sure how much mixing you get. You might end up preferentially, because the density is less, it flowing in a different way.
Well, there's some 150 cc's of spinal fluid up in this area total, correct? Up in this area?
Probably in a woman of this age, I would say maybe 120, 130 milliliters of fluid in the brain, around the brain, up above the chin, so to speak.
Sure.
And how much of that would be able to move out, don't know.
Okay. And of course, you said that depends on how long someone is in that position for gravity to take effect, correct?
Yeah.
And Dr. Leedsmith, if someone is seated in basically this position, the gravity would have the effect of, I think you even testified a little earlier, the gravity would have the effect of going down the path of least resistance, which is back of the throat, down the airways. Those are all relaxed and flaccid after death, correct?
Yeah.
And at some point, if that person was in that position for some 12 hours unmoved, then at some point transported, turned left, turned right, placed on a gurney, moved to the coroner's office, that could account for blood in the alveoli. I think that's what
I just don't know. I have no way to answer that. I'm just saying my experience would indicate that it takes something on the part of an expansion of a chest, passive or active, to get things out into the alveoli. But I can't. It's a very interesting question you ask, and I can't answer it.
Dr. Leedsma, my last point, when the spine is transected, you would not expect notwithstanding some of the rigidity that you've talked about, some of the tremor movements in the diaphragm that are possible, you would not expect for Lana Clarkson after her spine was transected. And when I say after, I'm talking about seconds after, not the milliseconds of the expulsion, all right? I'm talking about starting at 1, 2, 3, 5, 10 seconds after. She could not sneeze.
She could not what?
Sneeze, correct?
No.
She couldn't cough.
In the classic sense, no.
She couldn't scream.
No.
She couldn't exhale deeply.
Depending on if this was chest and abdomen, something like that could occur, but these other things you talk about predispose. When we cough, we close off our airway, we build up our pressure, and then we release it. That would not have been possible after her spinal cord was injured as it was.
So what are you saying was possible after her spinal cord was injured?
I'm saying, as I've indicated before, there's a combination of the expulsion of gas by simply elastic collapse of the chest, aided perhaps by reflex contraction of the chest and abdominal muscles, which could produce I don't think it is a cough. It's not, because if that has certain anatomy and physiology. But something like that, an expulsion of breath and whatever it carries with it.
And that would basically be contemporaneous to, that's the word I was searching for, I couldn't find it before. It would basically be contemporaneous to the gunshot.
Yes.
Thank you.
All right, go ahead. He's done. For now.
Doctor, just a couple of follow-up points to some questions that you were asked by Mr. Jackson. When you talk about a cough in the classic sense, you were trying to explain that the muscles involved in a typical cough wouldn't be able to react given her injury, correct?
Yes.
And when this irritation would occur, when blood or whatever might get down into the esophagus, that would produce a cough-like reaction. Is that correct?
It's the best way. I mean, what words have we got? We have to approximate what we know and then modify them a little bit, and that's what I've tried to do.
Okay, and so you used the words, not a classic cough, or you used the word woof or whatever,
right,
to explain one type reaction that could occur. That could occur when the blood or the other caustic materials would engage and get into the esophagus, correct?
Yes.
Okay, and why does that occur that way? In other words, if let's say blood would get into my esophagus right now, why would there be a reaction to that?
Well, as I've indicated, there's going to be two components. A passive one, simply because you've got an elastic expansion of the volume back in the back of the throat and the upper airway and probably the esophagus that has gas under higher pressure on it. And then when that diminishes, is no longer driven in there, then it does what gases do, is expand back out the other way. Then there could be this reflex component that we're struggling with the words for, cough-like or woof-like expulsion that's chest and abdomen, non-volitional, that added to that or follow it. I'm not sure what the time frame is. It's probably very quick.
Okay. Basically, just to kind of separate these events or potential events, because you really, in this case, it's just you don't know exactly if it happened or when it happened, essentially. Is that correct?
That's right.
Okay, but you know it can happen. Is that correct?
Yes.
And it's reasonable for it to have happened. In other words, it's not unreasonable to believe that one of these cough-like events occurred, correct?
It's perfectly reasonable.
Okay. Now, contrasting that to something that you talked about with Mr. Jackson regarding the blood getting into the alveoli, basically that requires some type of pressure or some way to get it in there. Is that correct?
That's kind of what we were taught. That's kind of what I accepted, and it seems reasonable from personal experience to see that.
Okay, and essentially from his hypothesis or his theory that gravity could put the blood in there, that's not something you were taught or you would find to be reasonable. You'd have to see some proof of that, correct?
I don't have any, but you know the way Mr. Jackson has.
I'm sorry, Doctor. I want to interpose an objection. It just dawned on me that Mr. Plord added something in his question that is exactly opposite of the doctor's testimony. He said it would be reasonable. He's not sure if it happened or not.
Just phrase your question again, would you please?
Isolating on this particular theory that Mr. Jackson was presenting to you, that gravity could account for the blood in these air sacs. That's not something that you're aware of, that you're just saying that that's something theoretically could be proven if somebody wanted to prove it.
That's a fair way to state it.
Okay, you're not saying it is even reasonable to have happened in this case because you have no background regarding that, correct?
Objection misstates the testimony.
Well, he's asking him if that's what he's saying, so I'm going to allow the question, and if you want to go into it and recross, you may.
Yeah, I haven't explored all these possibilities. I've done no experiments myself. I'm just saying that given what I understand about these processes, it seems to take some negative pressure within the chest to enable this material, red cells, to get out in the alveoli.
Okay. And in that finding, you know it's there because it's actually been documented in the autopsy. That would be consistent with this inhalation, exhalation process occurring after the shot was fired. That would be one possibility that would be reasonable, correct?
That's correct.
Okay. And you wouldn't expect there to be any type of a large breath or a large volume of material to be in the lungs absent the point in time when the shot was fired, correct?
I don't see how this person could have done that. Take what we're describing as a deep breath.
Okay.
I just don't think that'd be possible.
Okay. Now, we don't know in this particular case how much air was in the lungs at the time, correct?
No.
The lungs could have been either full or half full or empty, as far as we know, correct? Right. Okay. And
How much longer do you have to go?
I'm going to try to get done in about 3 minutes.
Well, do you have some more after that?
Not yet.
Okay. Ooh.
I want to make sure we have to get the jurors fed. They get surly if they don't get fed. So I don't want to go too long. The caterers need time to set up. All right, go ahead. Let's see if we can finish with the witness.
Okay, let me just get to the deceived rigidity. You're talking about that reflex where the neck and head and back go back and the feet go out. You really don't know whether that happens within a second or 2 seconds or 3 or 4 or 5. It can happen, all right.
Oh, I don't.
And over and above that, setting aside that reflexive rigidity, can there be movements of the body, involuntary movements, muscle movements, aside from that rigidity issue?
Correct. There can be.
In these, head moving from one side to the other for one, is that correct? Muscle contractions.
I wouldn't want to limit it.
Could be
Such
arms.
things could happen.
Okay, so, and that's different than the rigidity issue where somebody stretches out.
That's right.
Very good. Thank you very much. I think that's it.
Thank you. Recross.
I was about to pass the baton. No, I'm fine.
All right.
Nothing more.
Subject to recall, thank you for being here. You may step down. Keep in mind the admonition, we're in recess till 1:30 this
Okay, this is Pauline Rosenfield, and she is an RN emergency room nurse. I wonder, oh Lord, please tell me she's not the nurse that took all the swabs. Because I really don't want to hear testimony about swabs. Please, God, don't let her be that one. Oh, Lord Jesus, please don't let her be that nurse. Because I don't want to hear testimony about that again. I really, really don't. Alveoli. Alveoli. Okay, here we go.
We have remaining the last issue before we move forward this afternoon. Not the last issue, the last issue for right now. You wish. I know. And that has to do with whether or not the people can call, what's the name of the witness, please? Deborah Robitaille, rebuttal. I've taken a law that they gave me this morning, and I've found some other cases which I think are more on point, but it also causes me to make certain inquiries. I need to ask the people why Ms. Robitaille was not called in your case in chief.
Your Honor, at the time that we found out Robitaille even existed, we had already begun the case. We had basically prepared, and whether or not we were comfortable at the point at which we found out who she was and where she was and what she might have to offer, where we were on our case in chief. We had already gone through, if the court recalls, we had gone through the 4 1101B witnesses right at the outset, right at the beginning of the case, and that's sort of how we blueprinted our case. We wanted to move from one point to the next, and we were pretty successful in doing that with very little interruption with our witnesses. There was information that we needed to vet with Ms. Robitaille. Nobody had talked to her. She lived out of the state, across the country on the Atlantic seaboard. I didn't have a chance to meet her, never talked to her on the phone. We sent an investigator out to talk to her. By the time we got the report back from the investigator, we were well into our 1101B case and basically finishing with that area and moving on to other areas. There was some information in the report that we needed to explore and expound on. During that time, we asked the court preliminarily, is this someone that you would allow, because it was relatively late discovery, is this someone that you would consider allowing us to call? And you found her to be relevant. That notwithstanding, we felt like under cross-examination there was still information that we needed to vet, that being, had she spoken to media outlets? If she had, what had she said? Where are the interviews, et cetera, et cetera. There's no way that I was going to put her on, or that Mr. Dixon would put her on without, by the time done.
StreamYard.
We would just leave it for what it was. The defense then put on their case. And that answers the question as to why we didn't put her on in our case in chief, knowing full well that we were relatively, by the end of the case and by the beginning of the defense case, we're getting comfortable with who she was, what she said, and what potential cross-examination she may be vulnerable to. Now the defense case is put on, and the attack is almost immediate on one of the 1101B witnesses. That attack is an attack not just on Melissa Grosvenor, but on all the 1101B witnesses. Each one of them was attacked in their own way on cross-examination, but then when you get to the defense case in chief, that's when the real ammunition was fired at the 1101B witness, Melissa Grosvenor. The argument that the defense is reasonably going to make is, if this woman is lying, if she made it up, then you can assume that the others are in it for the same purpose. That argument is substantially rebutted by mere numbers. The fact that Deborah Robitaille is yet another independent witness who has experienced almost identical circumstances as the four that the jury has already heard about will undermine or rebut that argument. That's why we asked to use her in rebuttal, and that's why we didn't use her in our case in chief.
Okay, thank you. Mr. Bruno?
I'm going to have to dispute the timing aspect of this. We were provided a interview March 22nd, March 29th, that precedes my filed a motion to exclude her testimony based on several reasons, late discovery, cumulative, etc., which was litigated before the jury was sworn. So this isn't a situation where they found out about her after the case had begun, after their case had begun. That simply is not the case. They knew about her at least a month before the jury selection even began. The attack, if you want to call it that, on Melissa Grosvenor was that Melissa Grosvenor did some dishonest things in and of herself.
Well, and then because of that, she's to be disbelieved in her testimony.
It's to discredit her testimony, but that doesn't mean that if Grosvenor had been at the judge's house when she stole the plaque, or if she'd been at the bank when she stole the money, and could say something about Pileggi or Robitaille had been from Grosvenor, that would be rebuttal to that specific attack. A generalized rebuttal is not rebuttal. I mean, the case Carter, the seminal case on this, says that
Carter's not the seminal case anymore. It's an important case. It's not the seminal case.
Well, it's seminal in the sense that it was one of the first expositions,
Okay.
not seminal in the sense that it's the last word. But I mean, this is not proper rebuttal. I mean, this is kind of almost like Potter Stewart said about pornography or obscenity. You know it when you see it. You know that this was held back for this very purpose, to have undue emphasis placed on it. This is a tactical decision. This is nothing other than a tactical decision, and I think that it's improper to offer it at this point in time.
Okay, thank you. I'm prepared to rule. There are some recent cases, or several cases since Carter, which was decided in 1957. There's two fairly recent cases from the California Supreme Court, People versus Young, which is found at 34 Cal 4th, 1149, and a case that is very close to being on point. Nothing is ever directly on point, or rarely, which is People versus Gates, which is an earlier case, a case from 87, 43 Cal 3rd, 1168. And Gates actually is very, very close to the facts of this case, having to do with one, or on the particular facts of this case, and it's actually citing another case called People versus Lanphear at 26 Cal 3rd, 814, and that's Lanphear. It can also be considered case in chief put on out of order. And things that I have to look at in this matter, and you have mentioned some of them as to what I'm looking for when the people seek to call a witness that could have been called in an earlier time, certainly that was possible in this case, is whether or not, one, the people are calling the witness to gain an unfair advantage, which you've argued they have. I don't agree with that. Given the nature of that particular evidence, there are 4 witnesses who've already testified under 1101B. To say that one more witness would give it undue emphasis, and it's not going to be the last word. We know that you haven't even rested your case yet. The witness, if she testifies, will testify today. So I don't think there is undue emphasis. Certainly there is some emphasis. Another issue that the court has to consider is whether or not, one of the things I have to be concerned with is to ensure the presentation of evidence is orderly and avoids confusion of the jury. I would look at where we are right now. That can't possibly be argued. We're not even sure. I mean, I know where we're at. We're in rebuttal of a defense case that hasn't rested. And to some degree, we're in sur-rebuttal as well. So to say that it affects the orderly presentation, not under the facts of this case. And perhaps the most important one is to avoid unfair surprise of the defendant from confrontation with crucial evidence late in the trial. There is no surprise. You've known that this witness existed. You know that there was a chance that she would be called, as you said, back in March of this year. The witness and her testimony are not a surprise. Whether you call this, and nobody's really calling it part of the case in chief out of order, because I don't think that would be appropriate given the presentation the parties have made as to why this witness is being called. But I do believe that this does properly qualify as rebuttal evidence. Clearly, even though it has come in cross-examination, and that issue has been raised, though not squarely decided before, as to whether the impeachment comes by way of witnesses in the case in chief or cross-examination. Clearly, this part of the argument comes from cross-examination, which is that through cross-examination you have impeached Melissa Grosvenor as well as other witnesses, basically. I mean, the cross-examination is to show that they're being untruthful, that they all have reasons for not testifying truthfully, that they've made the story up for one reason or the other, and I think that applies to each of the 1101B witnesses that has been presented. There are, although they are not perhaps as large as some of the other reasons, there are reasons. It does tend to, you did present witnesses that impeach Melissa Grosvenor, and again, this tends to show that Melissa Grosvenor and the other 1101B witnesses were telling the truth, that there's a series of witnesses, and to say there's strength in numbers, that is a truism. Indeed, there is another very slight, are you planning on, I need to, before I make this part of my ruling, you indicated you wanted to go into the relationship with the individuals who either own or are investors in the backstage? Yes, right. As slight as that may be, that is a legitimate reason. There is a suggestion that Pumpkin Pie, whether the jury finds that to be true or not, is testifying because of a business relationship she has and the relationship of certain individuals in that business with Mr. Spector. For all those reasons, I find that, especially under the reasoning of Young and Gates, that this is appropriate rebuttal. It does not fall within the prohibition of the Carter case. In fact, the Carter case is mentioned often in both Young and Gates, and therefore I will allow that witness to testify. So at this point, are you ready to proceed with that or some other witness?
Another witness, Your Honor.
All right, you may proceed.
No, before we call that other witness, may I offer a stipulation? Well, I should do it in front of the jury. May I offer a very quick stipulation? It's just as to the sign. Mr. Rosen and I have already talked about it.
Certainly.
We'll just do it once the jury comes in, and then we'll call the first one.
Okay.
Okay, thank you.
All right, let's bring in the jurors.
Is that okay?
All right, the jurors and the alternates are now present. Do you have a stipulation you want to offer, Mr. Jackson?
We do, Your Honor. Maybe this will make a little bit more sense. I have an 8.5 by 11 document bearing 2 photographs, A and B. I'd like to have this marked as people's next in order. I think it's 184.
It is 184.
I'll just place that on the overhead.
$184.
184. And I would simply offer Mr. Rosen the following stipulation. Mr. Rosen, will you stipulate that the sign as it appears in photograph A and B of People's 184 is as it appeared on February 3rd, 2003, and it no longer appears that way.
Well, my eyes aren't that good.
It's right here. It reads Pyrenees Castle.
No, I can read B. My eyes aren't quite as good as read A, but I can see it here on the Elmo. Yes, I'll stick with it.
All right, thank you.
Thank you, Your Honor. With that, I can photograph.
Do you have another witness?
Yes, we do, Your Honor. Thank you. We call Pauline Rosenfield.
Okay.
Please raise your right hand to be sworn. You do solemnly swear that the testimony you may give in the cause now pending before this court shall be the truth, the whole truth, and nothing but the truth, so help you God.
I do.
Thank you. Please proceed. Please state and spell your first and last name for the record.
My name is Pauline Rosenfield. It's Pauline Rosenfield.
Thank you. You may proceed.
Thank you, Your Honor. Good afternoon, ma'am.
Good afternoon.
Could you,
Pull that microphone all the way back. There you go.
thank you for coming, and I think you've been waiting for a little while, so thank you for that, too. Could you tell us what you currently do for a living?
I'm a registered nurse at Cedars-Sinai, and I work in the emergency department, and my position is pre-hospital care coordinator, which essentially is a liaison between the mobile intensive care nurses and the paramedics that service our area. I essentially oversee the QI program there, the continuing education program, and just make sure everything runs smoothly.
There was a lot in that answer, so let me ask you.
Okay.
QI, what's that, QI program?
Okay. Quality improvement.
Okay.
We have certain programs that we do to make sure that whatever the paramedics do in the field and the MICNs do in the emergency room as far as pre-hospital care goes, that it's all done correctly via DHS guidelines.
I was going to welcome you to this trial. You speak as fast as everybody else does. We don't get any slow talkers.
I'll slow down.
Thank you.
I'm sorry.
Appreciate it.
Let me ask you another question. I think a couple times in that answer, you used the term MICN. Is that correct?
Correct.
What is that?
MICN is Mobile Intensive Care Nurse.
And what does that mean?
This is a nurse, a registered nurse in the emergency department who has been specially trained to do online medical control with the paramedics in the field, essentially oversees treatment of patients in the field according to the guidelines set by Department of Health Services.
But you're employed by Cedars-Sinai.
Yes.
And you work, I think in that last answer, you mentioned the Department of Health
Department of Health
Services.
Services.
Is that part of the County of Los Angeles?
Yes, it's LA County.
Before we go any farther, let me ask you briefly to outline for the jury your background, training, and experience for your present position.
Okay, I've been a registered nurse for 30 years. I've worked at Cedars for 30 years. I have essentially started my career on a medical teaching floor for 3 years, went into the intensive care unit for about 3 years, then went to the emergency department, and I have been there now for 26 years, and have been the pre-hospital care coordinator for the last 5 years.
By pre-hospital care coordinator, are you a supervisor?
Yes.
And do you supervise other nurses who are MICN nurses?
Correct.
Okay. Let's talk a little bit about that. First, how many other nurses do you supervise?
We have 43 RNs that have this certification of mobile intensive care nurse.
Tell us a little bit about that certification, which you have, correct?
Correct. Correct.
What does that certification mean? What's the purpose?
To become a mobile intensive care nurse, you need to have been a nurse in the emergency room for at least a year. You also have to take it's a development program which lasts about 2 months. It's a 48-hour program, and you learn essentially how to take care of the patient according to Department of Health Services policies and procedures. And you learn how to direct the paramedics in the field when it comes to taking care of patients.
By the way, at this time, do you know a nurse who works in that area at Cedars-Sinai by the name of Susan Levitt?
Yes, I do.
And is she one of the people that you supervise?
Yes, she is.
And does she have a distinctive accent?
Yes, she's Australian.
Okay.
It's very distinctive on the radio.
And is it true that each of the nurses that work for you in this area have a designated number that they use in this process that we're going to talk about, working with the paramedics in LA County?
Yes, when you become a mobile intensive care nurse, you are given a number that you use to put on the form after your name. This essentially says that you have passed the county test and that the county has certified you. So all of us have our own special number.
Your number is?
1619
Okay. And Miss Nurse Lovitz?
is, it's 2850.
Okay. Let's talk a little bit about this program that you work in. You work for Cedars-Sinai, as you told us, but, correct?
Correct.
But you also work in conjunction with the County of Los Angeles Health Services.
Correct.
And one of their responsibilities that you work with is Los Angeles paramedics who work in the county.
Correct. Cedars has certain rescues, certain provider agencies assigned to them. We have LA County, LA City, and Beverly Hills. And these paramedics bring their patients to our facility. So I essentially oversee the program in the sense that I check all the base forms. I make sure that the treatment and care that was given to the patient by the paramedics is appropriate, and also by the MICNs.
Before you were a supervisor, did you actually do this job that we're going to talk about?
Well, not this particular job, but I was an MICN.
Okay. Where you work with paramedics?
Correct.
Okay. An MICN nurse, or what would their job, for example, we're going to talk about a specific day, December 24th of 2001,
Correct.
just before midnight, correct?
Correct.
You've looked at a number of forms, in fact, listened to a tape of, for want of a better word, paramedic run that your Nurse Lovett at Cedars-Sinai communicated with LA City Fire paramedics, correct?
Yes.
Okay. So let's talk about that. You're familiar with the duties of a nurse in that situation directing paramedics?
Correct.
And what are those duties?
Well, once a run begins, the MICN gets on the radio and listens to the assessment done by the paramedics. And according to the assessment, the chief complaint, what's going on with the patient, she then determines what type of treatment that the patient needs. And then she works in conjunction with the paramedic, essentially getting any more information that she might need to go ahead with this treatment.
So in that situation, the paramedic is obviously with the patient,
Correct.
and the paramedic is relaying whatever they see, whatever injuries, whatever needs that the paramedic assesses at Cedars-Sinai.
That's exactly what they do.
And asking for the hospital or the nurse's okay. Hospital?
Yes, Base Hospital is a hospital and care to patients in the hospital, and this is all done according to the guidelines that have been set up by the DHS agency.
By Department of Health
Department of
Services.
Health Services.
Okay, all right. We're talking, and you mentioned that you knew Nurse Susan Lovett, and you did at for 24th, 2001. Pardon?
Still laying a foundation for certain things. You may proceed.
You mentioned that you knew Nurse Lovett on the day we're talking about, December 24th of '01, correct?
Correct.
Were you familiar with her background, training, and experience? Was she one of these MCIN?
MICNs?
Yes, correct.
Yes, she
top third of it. I don't have to get out my glasses. Do you recognize this form?
Yes, this is I'll use to record the information that paramedic gives the MICN when they're actually doing a paramedic run.
And it's made out in the normal course of business at the hospital, correct?
Yes.
And when's it made out?
I'm sorry.
When is it done? When
It's actually done when the nurse is on the radio speaking to the paramedic.
While they're engaged in the run?
Yes, it's done concurrently with the run. She's writing as he's speaking, and she's recording all this information on this particular form.
And her job is to record the information correctly and truthfully at the time?
Correct.
Because this is an important document?
Yes.
Why?
It deals with patient care. Essentially, we have to determine what's going on with the patient in order to give the right care. And that's why essentially documenting is important, so we can go back and look at this and make sure that what we're doing in the field is appropriate.
In fact, do you understand that there is some kind of quality assurance unit that goes back and reviews some of this information from time to time?
I, as the pre-hospital care coordinator, review every form. I have to look at every form. That's part of my job, just to make sure that what has been done in the field is correct.
Now, in any given run, and when we talk about a run, we're talking about the time that the paramedics are with a patient from the time they pick them up until they get to the hospital, if that's where they're going, correct?
Yes.
Is that the term for a run?
Yes.
Okay.
That's
so
correct.
with respect to every run, is it fair to say that there are two separate ways to document the medical information in that run? One, the base hospital form that we're looking at, People's 57.
Yes.
And two, the radio transmission, if it's recorded.
Yes, and we record all of the transmissions between the medics and the MICNs.
When you say you do, is that Cedars-Sinai or is it the Department of Health Services?
It's Department of Health Services policy, and we do as well.
So every one of these runs is tape recorded and stored, is that correct?
Yes, that's correct.
And the same thing with People's 57, the base hospital form.
Yes.
Is that right?
Yes.
Okay. Let's briefly talk about this a little bit. As we look at it, well, first let me withdraw that nasty list. You have the whole form in front of you. Someplace on the form, the nurse who was engaged was the MICN nurse at Cedars-Sinai, documented their identity on the form. Is that correct?
That's correct.
At the bottom of the form?
It's at the very bottom of the form.
And what nurse was handling this?
This was Sue Lovett.
With the number that you gave us, N2850,
I
correct?
believe it's N2850, yes.
Okay.
It's kind of cut off on this form.
Is there one other, as we look at the top portion of this form, People's 57, at the top right-hand corner of the document, I see a number that starts with BD. Could you tell us what that number is?
This is the sequence number, and this is the number that the paramedics have on their form that they fill out. They give us this number over the radio. We put it on our form, and this is the number that connects the two, essentially, documents together, so we know we're talking about the same patient, since we do not use patient names.
So from this document, we don't know what the patient name is.
No.
Are you familiar with an LA Fire Department form 9902M?
Yes.
Okay. That form would show the name of the patient.
Yes, they do record the patient's name on the form.
But it also has the same BD number, is
Yes,
that
it's a
correct?
sequence number. It's the same, yes.
Top left-hand part of the document, we see a number, and I don't think it's cut off, 1642259. What is that?
That's a
This is something else I don't get. Okay, so she broke her wrists and she couldn't work. I got that. And I get how that's an important thing. Because if you don't have steady work, like, okay, I was a nurse. I hurt my back and I was out of work for like 7 months. And I got disability through my work while I was out. Well, if you're an actor, you don't get that. So I totally get why it's important that they need to know she broke her wrists. I get that. Why have we talked to, this is the fourth person about her wrists? Okay. Why? Why are we going over the form that they filled out again? I just don't get it. Why? Ugh.
Hospital given number, that just helps us essentially number our forms. So that's just strictly for the hospital.
Now, you said that's a hospital number for Cedars-Sinai.
Yes.
Is this, though, a Cedars-Sinai document or a Department of Health Services for the County of Los Angeles?
This is a Department of Health Services form that all the bases use to record information.
So no matter what hospital in Los Angeles County, they would use the same base hospital form?
Yes, they would.
But is it a policy of Cedars-Sinai in this program to use this form?
Yes.
Okay.
Yes.
And in fact, you've checked and this form came from Cedars-Sinai, was filled out that day?
Yes, it did.
Okay. All right, well, let's try to go through this somewhat quickly. As we look at the, right below the hospital sequence number, we see the date, correct? And
That's
the time?
the date of the run, yes.
So as I suggested, December 24th of 2001?
Correct.
Now, there's a time on it, and we should talk about that. It says 23:35 military time,
Yes,
right?
we use military time, and that is the time that the run actually started. The transmission went on between the paramedic and the MICN.
Okay, so this is the time that the paramedic got on the radio and started talking to the hospital.
Yes,
Okay, so that would have been 11:35 our time,
correct.
PM.
PM, yes.
Okay, all right. And then as we go across, we see some other numbers. Next one over, it says RF 27.
That's City
RA.
City Rescue 27.
All right, and that would have been the LA Fire Department rig that the paramedic was in, correct?
That's correct.
Okay. Go over a little farther, and we have the age and the sex and the weight of the patient, correct?
Yeah, that's all basic information that we get for every patient, yes,
Right, and that would have been given by
by the paramedics.
paramedic to your nurse at Cedars-Sinai.
That's correct.
And she would have written it down right at the time,
Right,
like all this other information.
correct.
And then the last one on that section, it says hospital code, and then it indicates radios checked.
Right, the transmission came across on our paramedic radio versus a phone line. We have both ways of communication, and this was a radio call.
So the paramedics have two options. One, to use a radio from their paramedic rig.
Yes,
They also could get on a landline or even a cell phone, I imagine.
right.
Okay. So we know this was a radio transmission.
This was a radio transmission.
And as you've told us, Cedars-Sinai, as a matter of policy, tape records and keeps these radio transmissions.
Yes, we do.
Okay. Going down to the next section, chief complaint, and from then on to the next few lines, could you tell us what that's all about?
Sure. This essentially, the chief complaint code is a code we use to describe the injury. BR essentially means blunt fracture, and it describes that the patient had a blunt fracture. And as you continue on reading, she describes essentially what actually happened. The patient fell on the carpeting while dancing, had real wrist deformities, meaning that both wrists had injuries to them. A good capillary refill pre and post splinting. She's just essentially identifying the fact that the patient had a good pulse and had good color and sensation to the extremity pre and post splinting. We want to make sure that that occurs. Again, let's see, asthma is her medical history. She's on albuterol, and let's see, she's patient's allergic to penicillin and sulfa. That's a definition, or that's abbreviation for sulfa. And then up above there is a no ETOH designation there, which means no alcohol. This essentially is a pertinent especially in a case, and this would be a parameter for essentially being able to medicate someone.
And again, this is all information that Nurse Susan Levitt would have written down in response to what the paramedic was telling her over the radio. Is
That's
that correct?
correct.
And you mentioned no alcohol in light of the treatment I'm going to have a few more questions about that, but I think we'll come back to that and we'll move on here. Looking at the next line down, do you see where it says conscious?
Yes.
What's this box all about, and what information would have come to Nurse Lovett to make her fill out the form?
Okay, essentially, we are identifying the level of consciousness of the patient, and it's documented here that the patient was alert and oriented, meaning the patient was alert and oriented to time, place, and person. And then if you go across the form, you'll see something that says GCS, and there's a number there, 465, and this also identifies that the patient is alert and oriented. It's a scale that we use for essentially identifying the state of consciousness of a patient.
Well, with respect to those two boxes, consciousness and then the GCS, I assume, and tell me if I'm wrong, that there are different levels of consciousness
Yes,
and
there are.
alertness.
Yes.
What does this form, People 57, tell you about this patient on this day, at least as far as what the paramedic told Nurse Lovett?
Essentially, it says that the patient is completely awake, alert, oriented, and has essentially all their senses about him.
Okay. Sudie, could we go to the bottom half of the form? And I'll have a couple more questions. At the top, now we're looking at the bottom half of People's 57, the base hospital form that we've been talking about. And as we see it here, we're seeing the bottom half, but at the top of that bottom half, or sort of in the middle, we see splint both. Do you see where that is?
Right.
Okay. Tell us what information is there that the paramedic told the nurse over the radio.
Okay. Essentially, the paramedics went ahead and used splints to stabilize the injuries, which apparently were on both of her extremities, her wrists. Also, the nurse gave an order for morphine, 5 to 10 milligrams to titrate IV push. This essentially is giving the patient medication to help the pain control, and titration means that the medication is given to the patient according to pain, so as little as 5, as much as 10 could be given.
Push, what does that mean?
Push. It means that the medication, what we do is we'll put a little catheter into the vein, it's a little IV site, and the medication is pushed right into that catheter, and that's considered IV push.
Well, Mr. Jackson's lent me his pointer here, so maybe we can quickly go through the rest of this, and I'm going to point. At the next level down, right where I'm pointing now, there's a check next to fracture, and then on the other side of the form, same area, it says fall. Tell us what that's about.
This is the trauma section of the base hospital form. It identifies that the patient had a blunt injury and had a fracture, so that's what the BR means, blunt fracture. Then if you move across, it says mechanism of injury, and this tells you how the patient sustained the injury, and it's from a fall. That's what the FA is.
Okay, fine. And then last, just about last, at least with respect to the form, down here in the bottom left-hand corner, it says time clear, and that has a time in it, correct?
Yes.
And that is?
This is the time that the paramedic and the MICN actually finished their communication, the transmission ended, and that is the time 23:38.
So all of this took just 3 minutes?
Yes.
Okay. And then right at the bottom, it's a little bit cut off. Down in this area, there's a number that we talked about for Nurse Lovett in 2850, correct?
That's right. That's where her name goes.
All right. You
Purposes, yes.
we have the transcripts. The jurors have already listened to it. If you like, I hand them out.
I don't think it's necessary.
All right. Thank you very much.
Well, whose voices are you attempting to have her establish?
Nurse Lovett.
As soon as Nurse Lovett talks, if she can ID it, that's all she needs to do.
Well, it's only if you want me to say this to the bench, I will. But there is another portion where I'm going to ask her for her medical opinion.
If she needs to listen to that to interpret it or to give an opinion, that's fine. You may play it.
Rescue 27, I'll copy you loud and clear. Go ahead with your run, please. Bravo, David, 4640. We're called to the home of a 39-year-old female, 140 pounds, who we find awake, alert, oriented times 4. Patient was dancing on a carpet, slipped, fell, and fractured both her wrists. We have significant deformity on the right wrist and not as bad on the left. We have the patient loaded in the back of the rescue at this time. We have both wrists splinted. Blood pressure 130 by palpation. Pulse is 80 and regular. Respiratory rate 20. Clear bilaterally with good tidal volume. No other significant trauma. No neck pain, no back pain, no shortness of breath, no chest pain, nothing like that. We do have good capillary refill and pulses distally to both fractures, pre and post splinting of both of them. Patient is in a significant amount of pain, and due to not having any other trauma on our patient, we were wondering if we could get an order for some morphine for her. She has a history of asthma, and she is allergic to penicillin and sulfa, and she takes albuterol for her asthma. No other history, meds, or allergies, and we have a saline lock established at this time. O2 and the splint, and we're standing by.
Rescue 27, I copy your report. I understand you've got both wrists splintered right now and you do have a saline lock in this patient. Go ahead and push 5 milligrams of morphine IV on her. You can in fact give her up to 10 milligrams if you really want to. This patient hasn't been drinking alcohol, has she? Over?
She denies any alcohol consumption at this time, and she does not appear to be under any influence. We both slipped on the same rug. It's a very dangerous rug, so I don't think that was a factor at all. We do copy 5 to 10 milligrams of morphine, and
That's as much as I need for right now, if that's
Do
effective.
you wish the rest of it played for any purpose? Yes.
We stopped at the,
I know, I want to hold on. If the defense wants the whole thing played,
Okay,
I'll play
that's
it. I
fine.
want to see.
I don't see the need to request the rest of what you said. So I will.
Thank you.
all right, thank you, Your Honor. So, ma'am, you've just heard us play one. Do you recognize?
Yes.
You've heard that tape transmission before?
Yes, I have.
Okay, in fact, you've read the transcript,
Yes, I have.
and you have a copy in front of you?
I do.
First, we hear really 3 voices, but for the most part, 2 voices in that tape radio transmission. Do you recognize either one?
I recognize the nurse.
And the nurse
It's
is?
Sue Lovett.
Okay. Who was working under your supervision at that time?
Yes.
Now I'd like to invite your attention, maybe it's easier by doing so with the transcript, to page 4 at the last 4 or 5 lines of that. Could you turn to that, please? And I'll have a couple of questions.
Okay.
At some point, nurse, page 4, line starting at halfway through line 19.
I'm sorry.
Okay, I'll show you that.
Somebody called me.
And about halfway through line 19, Nurse Lovett says, go ahead, push 5 milligrams of morphine IV on her. You can, in fact, give her up to 10 milligrams if you really want to. And then she says, this patient hasn't been drinking alcohol. Has she? Over. Based on your years of experience in this job, Cedars-Sinai, supervising nurses in this area, why would Nurse Lovett ask that question? And was that within policy or not at Cedars-Sinai?
Yes, it's within policy. You want to check before you give any kind of a narcotic medication to a patient to see if they might have any other kind of drugs or medication on board that might potentiate potentiate this medication. So for her to ask that was perfectly acceptable and should essentially be done.
It should be done in your view?
Yes.
Before morphine is given to a patient with injuries like this, it should be inquired of the health professional whether or not she had been drinking alcohol.
Yes.
Or any other drugs?
Or any other drugs, not just alcohol.
So that was appropriate thing for her to do.
Yes.
And in fact, an important question.
An important question, yes.
Now, turning to the next page, page 5, at the top 3 lines, the paramedic Liverpool says she denies any alcohol consumption at this time, and she does not appear to be under any influence. As health professional, a nurse who practices in this area, what does that mean to you?
It means essentially if the patient's under any influence such as alcohol or drugs, paramedics, when they get on scene, are expected to look around a room and look for empty pill bottles, for...
I would object to this part. This is speculation. It's not within the ambit of this.
Oh, I disagree. She's part of this program, and she knows what the appropriate behavior they're supposed to do. Obviously, she wasn't on scene. She can't say whether they did. She's talking about what they're trained to do, which she has knowledge of. The objection is overruled.
You can complete your answer.
Okay, essentially they're expected to look for essentially objective evidence, looking for bottles, looking for any kind of pill bottles, any kind of drug paraphernalia. It just helps us essentially determine what state the patient's in. So that to me, is part of their assessment.
So in this situation, Nurse Lovett asked about alcohol, and then the paramedic responded that she denies alcohol consumption, correct?
Yes.
So as a person who practices in this area, does that mean to you that they asked?
Yes.
Okay.
That they asked the patient.
And that the patient denied any alcohol consumption?
Yes.
You made your point. You may move along.
And then the second part of it is, the paramedic tells Nurse Lovett she does not appear to be under any influence, correct?
Correct.
In an earlier answer just a moment ago, you said one of their jobs, one of the paramedics' jobs, is to make an assessment not only of the patient but of the area around them to determine whether or not drugs or alcohol might be involved, correct?
Correct.
Does this line tell you what I just read to you, that the paramedic did just that?
Yes.
That he made his own determination that she did not appear to be under the influence of either alcohol or drugs?
Again, I'm going to object.
Not necessarily. She did answer the question, and I think we can move along now.
And would you expect a paramedic in this situation to make those inquiries?
Yes.
Could I have a moment, please? Just a minute. Yes. Thank you. Nothing further.
Thank you. Cross-examination.
Thank you, Your Honor.
Afternoon.
Good afternoon.
We sort of have the same namesake. Yours just has a few more letters than mine does. I stop at the N. How do you prefer to be addressed? Miss, Mrs., Ms.? I
Miss.
can't call you Paula.
Okay, Mrs. is fine.
Mrs. is fine, okay. I'm going to ask you some questions. I'm going to follow up with what Mr. Dixon was talking about. We'll be here a little bit, not too long. As I understand it, you have been with Cedars for over 2 decades, is that correct?
Yes.
And you have been in their employ consistently during this, I believe you indicated, almost 30 years, correct?
In the hospital, yes.
So you're a real veteran at this, aren't you?
I think so, yeah.
Okay.
A long time.
All right. And you have a lot of experience. You are trained formally. You have a lot of on-the-job experience. And you basically have been doing this work for a long time, right?
Yes.
Okay. Let me ask you this. As I understand it, you are a registered nurse with all the qualifications. And I got to be honest with you, you rattled them off so quickly I couldn't get them down, but they were quite impressive, I will say that. Are you also a paramedic?
No.
Okay, so you're not a trained paramedic.
No.
And as I understand it, your employer is Cedars-Sinai. It is not the County of Los Angeles, isn't that right?
That's correct.
Okay. Do you know a gentleman by the name of Bruce Liverpool?
I don't know him personally, no.
Okay. How about a gentleman by the name of Daniel Stark? Do you know him personally?
No,
Neither.
no.
Okay. And it seemed like your CV was quite extensive, but the one thing I just wanted to ask you, because I don't know if I missed it or not, are you also a medical doctor?
No,
Okay, you're not an MD.
no.
All right. Now, Mr. Dixon asked you a number of questions about Nurse Lovett, and Nurse Lovett is one of the individuals who you supervise, is that correct?
That's right.
She's one of the 43?
Yes, she is.
Okay. And as of December 24th, 2001, so we're stretching back almost 7 years, about 6.5 years. How long had she been working at Cedars-Sinai in that capacity?
I'm not sure, but I know she was an MICN by 1996. I don't know the exact date that she became an MICN, but I know it was at least since 96.
Okay, since 96. So at that time, it was approximately about 5 years, is that right?
Yes.
Did she come to work directly in 1996 to Cedars in the MICN unit?
No.
When did she start to work at Cedars?
I don't know when she actually started to work at Cedars.
Okay, so what you can tell us is that she was MICN qualified in 1996, but how much before December 24th of 2001 she actually started her employment with Cedars, we don't know at this point. Is that a fair statement?
Yes, I don't know.
So she could have been working at Cedars for a day, a week, a month, or maybe even a year or two, or more, correct? We just don't know.
Yeah, I don't have the exact date.
Okay, that's fine, that's fine. And do you know what her formal training was prior to 1996?
Her registered nurse training? No, I don't.
Okay, do you know where she did it?
She's not all of it. I know where some of the trainings are, where she's worked in Australia and the United States.
Okay. Let me ask you this way, let me back up. On December 24th of 2001, how long had you been supervising Nurse Lovett?
Okay, I started this position in 2002, so in 01 I was not the pre-hospital care coordinator.
I see. So when Mr. Dixon was asking all those questions about People's 57, the base hospital form, as I understand it, when Nurse Lovett filled out this form, she was not working under your supervision at that time. Isn't that what you're telling us?
Yes.
Okay. So that gets me to the next question, which is, do you have the form before you?
Yes, I do.
Okay. If you need to refer to the form when I ask you this next series of questions, please let us know, and then the judge will let you know if you can look at it, okay?
Yes.
All right. I don't want you to look at it unless you need to. If you need to, then just alert me to that, and we'll work it from there. So, as I understand it, the form which we just saw up on the screen here, you did not supervise Nurse Lovett at the time that she filled this form out, which would have been on December 24th of 01, around 11:30, 11:35, correct?
Right, I was not in the position then.
All right. When were you first contacted and notified that you might be needed as a witness in this trial?
It was last week.
So up until that time, you didn't know who Mr. Dixon or Mr. Jackson were?
No.
Have you been following this trial at all in the news media?
Not really, no.
Okay.
No.
It's refreshing to find somebody that hasn't. And in terms of being contacted, who contacted you? Was it Mr. Dixon?
No.
Was some other person working on behalf of the prosecution staff?
Yes.
Okay, you remember that person's name?
Yes.
And what was that person's name?
It was John Little.
John Little?
Yes.
And how did Mr. Little identify himself, as a deputy DA or an investigator or what?
He worked for the fire department and was involved with this case.
So an employee of the fire department contacted you? Is that what you're telling us?
What happened was he called to see if it was possible to get a tape that was back in 2001, and since I'm the pre-hospital care coordinator, it was directed to me to see if I could get that for him.
And he told you, I'm sorry, go ahead.
And so that's how I got involved with this.
Okay, so Mr. Little told you that he was calling on behalf of the DA's office and he wanted to get a copy of this tape, the portion of which we just heard, right?
Well, yeah, he was,
okay.
Yes, he was.
Okay. And when was the first time, well, let me ask you this, did you get the tape?
Yes, I was able to get the tape.
And did you physically provide it to Mr. Little at a later time after that phone call?
No. I was also contacted by someone else connected with the case and was...
Do you remember that person's name?
Yes.
And what was that person's name?
Gene Daly.
I'm sorry?
Gene Daly.
And did Mr. Daly indicate to you that he was also working? Well, first of all, let me ask, is it a male or a female?
Gene. Oh, I'm sorry, female.
Okay. And I'll just use the term Ms. Daly. Did Ms. Daly indicate to you that she was working for the fire department like Mr. Little did?
No.
Did she indicate who she was working for?
She was, yes.
And was that the DA's office?
Yes.
And did you provide that tape to her?
Yes, I did.
And when was it the first time you met with Mr. Dixon? Today?
No, it was on Monday of this week.
Okay, so we're on Wednesday, so you met with him a couple days ago?
Yes.
And you met with him to discuss your testimony that you've provided here in court today before the jury?
Correct.
Okay. And as I understand it, Mr. Dixon, he went over your testimony with you, didn't he?
Yes.
And when he was talking to you, he had particular interest in several areas of your testimony, didn't he?
Yes.
In particular, he really spent time with you discussing that portion of the base hospital form that you told us and identified as, well, let's put it up there. Jen, do you have it, or should we have Sue put it up?
We just have a movie. Yes. We have it here, Your Honor.
Okay, Sue, did you put it up, please? Thank you. I need to speak. Chris. Now, that particular portion which is highlighted in yellow, which has a 0 and a line slash through it, and the letters ETOH, uppercase, capital letters. He spent some time talking to you about that, didn't he?
We talked about it, yes.
Now, that was an important part of his discussions with you on Monday, correct?
Sustained.
Well, let me ask it this way. He spent time discussing this portion of the report with you, the base hospital form report, correct?
Yes, we spoke about that in the whole form.
Sure, I understand. And ETOH stands for ethanol, which is a fancy term for alcohol, correct?
Alcohol, yeah.
And the 0 with a slash through it, that's kind of the universal sign for no.
Correct.
All right. And as I understand it, this is an official base hospital form provided by DHS and maintained as a business record at the Cedars-Sinai Hospital, correct?
Yes.
Okay. Thank you, Sudie. When was the first time, well, let me ask this. How much time did you spend with Mr. Dixon getting prepared on Monday?
Maybe 20 minutes.
Was that in person, vis-a-vis, face-to-face, or
Yes.
here in this building?
Yes.
Upstairs in Mr. Dixon's office on the 17th floor?
Yes.
Okay. And I'm not going to ask you what his office looks like. I know. We won't embarrass Mr. Dixon. Let me ask Mr. Dixon, I said I wasn't going to embarrass you. You know, you opened the door like that. All right. Let me ask you this. Did you speak with him or anyone else on the DA staff team between that meeting on this last Monday and today?
Yes.
And who was that?
I spoke with Gene Daly.
Okay, and who else?
And John Little.
Okay. So you've had a number of conversations, is that correct? Regarding your testimony.
Yes.
And when you spoke with Daly and Little, Gene Daly and Mr. Little, was Mr. Dixon present?
Yes.
And where did those conversations take place?
In his office upstairs.
Okay, and was that on Tuesday or today?
I spoke with them, on Monday in his
Okay.
office.
And that was after you had been interviewed, is that correct?
Interviewed.
Well, after Mr. Dixon
Yes.
interviewed you? Okay, and then after he interviewed, by the way, when he interviewed you, was Ms. Daly in the room?
Yes.
Was Mr. Little in the room?
Yes.
And they were all in the room when Mr. Dixon asked you the questions about the base hospital form and your experience as a nurse and Nurse Lovett, correct?
Yes.
So they were all there together, right?
Yes.
And did he play the tape for you in his office like he did here in court?
No.
Was this the first time you've heard the tape?
No.
When did you first hear the tape prior to today?
When I had to make a copy of it to give to Gene Daly. It's on a different format at Cedars, and I had to get it onto a CD so that they could play it. So I heard it then,
Okay.
when I actually did the transforming onto the DVD.
You actually did the transforming yourself?
Yes.
And was that at the hospital?
Yes.
Were you asked to listen to it?
No, but I was interested in listening to it, so I did.
Okay. You wanted to see what was
Wanted to
spoken?
see what was on the tape.
Okay, fine. So when was it that you first saw the base hospital form, which has been previously marked People's 57?
It was on Monday.
Okay. And did you look at it again today before you testified?
Yes.
Mr. Dixon actually met with you earlier today and chatted a little bit.
A little bit, yes.
About your testimony before you testified, right?
Yes.
Okay, so you've had several meetings with him, correct?
Yes.
All right. Now, as I understand it, you are not the author of People's 57, this base hospital form, correct?
No.
Okay. None of the printed or cursive handwriting, and I'm excluding for a moment the form printing on here, but none of the cursive, none of the printed writing is yours, is that correct?
That's correct.
And I think you said the first time you looked at this document was on Monday, is that right?
Yes.
So between December 24th, 2001 and Monday, which was, what was that? The 6th, right?
No.
Now, let's talk a little bit about the structure of this report. As I understand your testimony, this base hospital form is not with the paramedics, it's with the hospital, correct?
Yes.
And in this instance, it's with your hospital, Cedars-Sinai, correct?
A copy also goes to the Department of Health Services.
But that's after it's filled out.
Yes.
Okay. So let's just kind of take a moment and make sure that we all understand how this works. The paramedic, he or she is in the field, correct?
Yes.
The nurse, I think, am I correct? MICN nurse, am I saying it right?
Yes.
Okay. The MICN nurse, he or she is not in the field. That individual is at the hospital, correct?
Right.
All right. And, of course, this is a hospital that's working in conjunction with the Department of Health Services, right?
Yes.
Okay. So, Nurse Lovett, she's based somewhere physically in the hospital when this call comes in, is that right?
Yes.
Okay. And basically what she does is she receives this call. She serves, and I don't mean this in any negative way, but she serves in a sense much like an operator does or an information service officer when you dial 411 or 0 on your telephone, correct?
I can't really say that she's like an operator. I mean, she does record the information that she's given and processes it for a reason, and that's for the treatment of the patient.
Okay. So it may very well be that the nurse who takes this information, the MICN nurse who takes this information, may in fact never meet the individual who is phoning the information in. Isn't that right?
Yes, that's possible.
And in this particular instance, you have no ability to tell us, and I don't mean that in a pejorative way, but you have no ability to tell us whether or not Nurse Lovett from Australia even knew the lady or gentleman that provided her this information. Isn't that correct?
That's correct.
You don't know whether or not Nurse Lovett knew either Mr. Stark or Mr. Liverpool at about 11:30 at night on December 24th in the year 2001, do you?
No.
You weren't there when the information was taken, only she.
That's right.
Okay. You've been a supervising nurse for some length of time, correct?
Yes.
And in your capacity as a supervising nurse at Cedars-Sinai, one of your responsibilities, I think you said, was to review these reports, correct?
Yes.
And I'm sure there's just no possible way you can even begin to estimate how many of these you've looked at over the years, is there?
Many.
Tens of thousands probably, correct?
Probably thousands over the last 5 years, yes.
Okay. And most of the time, they look just fine to you, don't they?
Hopefully, yes, most of the time, but there are times when they're not correct.
Well, tell us about that. Tell us a little bit about that. When you That means you can answer the question. Tell us a little bit about when you look at it and they're not correct.
Well, when I look at the form, I have to make sure that there's a lot of boxes on this form that essentially just have to do with documentation. And if they're not filled out correctly, then I sometimes go back and listen to the tape and see if I can get that information. Also, there's destination policy that we deal with, determining if the patient's going to the correct facility, looking at the treatment guidelines to make sure that the treatment of the patient is correct. So there's different elements that I look at when I critique the form.
Okay. Now, you never critiqued this form, correct?
No, I did not.
Okay. And I guess what I'm asking at is this. It's not a 100% foolproof system. Sometimes mistakes are made, correct?
Yes.
Sometimes the mistake may be on the part of the paramedic, for example. Maybe the paramedic has made a mistake, correct?
Correct.
You're a professional, you're a veteran. You have, in your own personal experience, working at Cedars, found paramedics to make errors and mistakes, correct?
Yes.
And sometimes, unfortunately, the MICN nurse may make a mistake. Isn't that right?
Yes.
As far as we know, all the information that appears on People's 57, this base hospital form, came from the paramedic. Is that correct?
Yes.
By the way, when you look at this, and please feel free to look at it with the court's permission, of course. When you look at it, is there any indication here as to the name of the party that was speaking to Nurse Lovett and providing this information?
No, it's not recorded on this form, but the paramedic form has the name of the medics on it.
Okay. That's
so you can identify.
The paramedic form.
Yes, the EMS form, yes.
And hopefully the numbers match up so we...
Right.
Okay.
That's how they're identified,
All right.
yes.
Now, let's just for a moment assume that this information, because we've listened to a portion of the tape, came from an individual gentleman by the name of Mr. Bruce Liverpool, okay, who was a paramedic at the time. Okay?
Yes.
So as I understand your testimony, Mr. Liverpool, other than what she, Nurse Lovett, has advised him to do in terms of treating the patient, correct?
Yes.
Nurse Lovett would have only recorded what she was told, correct?
Right.
So, for example, if the paramedic, if Mr. Liverpool had made a decision in his own mind that ethanol, alcohol, was not involved, and he told Nurse Lovett that, then Nurse Lovett would have written that down, correct?
Yes.
And she would have only had to go by what he told her, isn't that right?
Yes.
As I understand it correctly, Nurse Lovett, she would not have seen this individual about whom Mr. Liverpool was providing information once the ambulance arrived at the emergency room at Cedars. Isn't that correct?
If the patient came to Cedars, she could have seen the patient come into the emergency room.
Okay.
Since the destination was Cedars and she was located at Cedars, so she could have seen the patient, yes.
You used the word could have, so let me follow up on that. Okay. Is there anything on this base hospital form, as you look at it, and with the court's permission, yes, please feel free to look at it, that indicates that Nurse Lovett saw this individual that evening?
No.
And you have no other information to indicate that that occurred, correct?
Correct.
So if in fact, if Mr. Liverpool made his own personal judgment that alcohol, ethanol, was not involved and radioed that in to Nurse Lovett, and Nurse Lovett never had the opportunity to verify that, she would only be able to record on People's 57, the base form, what Mr. Lovett told her. Isn't that fair?
Yes. If I can just add one thing with the paramedics.
Sure.
Paramedics are trained, they're educated, they're like our eyes out in the field looking at patients. So we essentially need to listen to their reports and hopefully get the best assessment of the patient that we can. And other things that they look at are things like if the patient's gait is steady, if they have track marks. I mean, they look at different things on the patient as well to help determine this decision that they make. And the fact that they ask the patient as well, that's all part of determining this particular decision as to the fact that there was no alcohol.
Okay. Now, you know nothing personally about the facts of this situation, correct? You
No,
weren't,
no,
you
no,
weren't
I don't
there
know
when
anything about, no.
the young lady was picked up, you weren't in the ambulance on the way there, and you weren't in the room when Nurse Lovett was talking to Mr. Liverpool, correct?
Right.
All right. There's nothing on the form here that talks about any field sobriety tests being given, any observations of gait, anything of observations of anything of that nature. It's not in here, is there?
No, it's not.
Okay. So let me ask you this. You already told us paramedics from time to time make mistakes, correct?
Yes.
All right. I want to go back to the tape for a moment, if we may. Now, you said that you retrieved the tape and you transformed it from one format to another format, placed it on DVD to provide it for purposes here in court, correct?
Yes.
You also told us that you listened to it at that point, correct?
Yes.
And you listened to a portion of it here today, is that right?
Yes.
Between the time that you prepared it and provided it to the prosecution and today, had you listened to it any other times?
I listened to it with Sue Lovett.
Okay. So you've listened to it 2 or 3 times?
Yes.
Okay. It's a very short tape, correct?
Yes.
I'm not going to play it again, but Your Honor, with the court's permission, I would like to play just one small portion of it. Thank you.
Well, you'll do terrific. Just location for it. Your best is 100% better.
I'm going to ask you to just listen to a portion of it. Sudi's already... Yes, I will. Already laying disclaimers. She's going to do her best, so we may get a little bit before and a little bit after. Page 4. Line 22. Page 5. Page 3. Okay. It might help also if I could just approach the witness, show her what I want her to focus on.
Okay.
Okay. What I want you to listen to is this part here. It starts right here.
Okay.
Up to there.
Okay. Okay. All right.
Ready? Okay, here we go.
And she does not appear to be under any influence. We both slipped on the same rut.
To 10 milligrams if you really want to. This patient...
A little bit, just a smidge earlier, please.
Patient hasn't been drinking alcohol, has she? Over?
She denies any alcohol consumption at this time, and she does not appear to be under any influence. We both...
Thank you very much, Sudi. Okay, you heard that?
Yes.
Okay, and you heard 2 voices on that, correct? You heard Nurse Lovett's voice, who asked the question, this patient hasn't been drinking alcohol, has she? Over. You heard
Yes,
that?
that was her voice, yes.
And then you heard a male voice say, she denies any alcohol consumption at this time, and she does not appear to be under any influence, correct?
Yes.
All right. So let's just take a moment and talk about this. Nurse Lovett inquires of the alcohol consumption, which according to Mr. Dixon's questions of you was perfectly proper protocol, correct?
Yes.
That's what she's supposed to do, correct?
Yes.
Because like you said, sometimes it's important to know whether or not somebody has consumed alcohol, or they've consumed a particular prescription drug, or maybe a controlled substance without a prescription, in terms of knowing how to assess the situation for proper treatment, correct?
Yes.
Okay. And I assume that's because there can be a danger if somebody's ingested something and the wrong medication is prescribed without the knowledge of what that person's ingested, right?
Yes.
All right. Let's look at the words very carefully, what is said by the male voice. The male voice says, in answer to Nurse Lovett's question, she denies any alcohol consumption at this time. Correct?
Yes.
All right. So that sentence indicates that it is she, whoever that young lady happens to be, is the one telling the paramedic no alcohol, correct?
Yes.
Now let's finish the sentence. And it goes on to say, and she does not appear to be under any influence. Did you hear those words?
Yes.
The words that were used by, and we'll say the paramedic, the male voice, was, does not appear, correct?
Yes.
That individual did not say that she was not under the influence of any drugs, or that he was positive that she was clean and not under the influence. What the voice said of the paramedic was, she does not appear to be under any influence, correct?
Correct.
And of course, as we push the fast forward button and we get to August 8th of 2007, today's date, we have no way to reconstruct what went on at that time that caused those impressions for that male voice to speak those words on it, correct? All we have is the tape, right?
Yes.
Okay. You have the court's indulgence, yes?
We're going to take a break. Ladies and gentlemen, keep in mind the ammunition. We'll be in recess for 15 minutes. Thank you.
Come to order. Court is getting in session.
All right, all the parties, jurors, alternates, and the witness are present. You may proceed.
Welcome back. I just have a few more questions I want to ask you, okay? I think when we we were talking about the medical form and the tape, and I just wanted to ask you one other question. In your experience, not only as a supervisor, which is your present position, but when you were working over the last 3 decades for Cedars, and I assume you had contact with patients just like Nurse Lovett did?
Yes.
Many times, correct?
Yes.
And oftentimes, isn't it true that when paramedics ask people, do kind of a intake at the scene, and they ask them if they've been drinking, sometimes people deny it, don't they?
That's correct.
Okay. Just a couple of other areas. Your Honor, I have a couple pages here that I want to have marked. I've shown them to Mr. Dixon. They're bait stamp numbers so that you can have it for your records, Mr. Dixon. 7571, 7572, and 7535.
How many?
Maybe 7585. Okay, I can't
How
tell.
many exhibits are we talking about?
It's 3 pages, and
Collectively, it's E11.
E11?
Yes.
Okay. And you recall the questions that Mr. Dixon asked you when he was showing you the base hospital form about whether or not this was, and I'm not going to go through all those, but you remember he showed you this and asked you if this was a official business record of Cedars-Sinai, the base form, People's 57?
Yes.
Okay. And you indicated yes, correct?
Yes.
And you're familiar with how the business records are kept there?
Yes.
Made at or near the time of the event in question?
Yes.
And they're accurate, correct?
Yes.
And they're kept as official records by the hospital?
Yes, they are.
And kept in the ordinary course of business?
Yes.
Okay. I just want to come up and show you a couple of documents here and ask you if these... All right. I took advantage of Mr. Dixon. I showed him to him previously without his glasses. Now he's got his glasses. Okay. While they're doing that, let me follow up on one other question. And isn't it correct that once the patient is brought into the hospital, those patients who deny drinking, it's turned out that in fact, in actuality, they had been drinking?
That can happen, yes.
Okay. And now we have to wait a moment so Mr. Jackson, Mr. Dixon can look at these. Then we'll have you on your way. Ms. Rosenfield, I think what I was asking you was about the fact that you were familiar that these records are kept within the normal course and scope of the business, and they are the official business records of Cedars-Sinai.
That's correct.
Okay. And during the break, did I come up and show you some records to give you an opportunity to familiarize yourself with it?
Yes.
And may I approach, Your Honor, please? Okay. This is for foundational purposes. And I want to show you, once again, what I showed you before, and if you just take a look at them, and when you finish looking at them briefly, you don't have to read every word on them, just take a look at them, and then I'll ask the questions. Okay? You've seen documents like this
Yes.
many, many times in
Yes.
your career, haven't you?
Yes.
And these are, in fact, official business records of Cedars-Sinai, correct?
Yes, they are.
Okay. Jen, could we have up first the patient profile, which that's 75, is it 75, 85, or 35? 85? Sudi, I'm going to need your help on this. Jen, is it 85 or 35? 85. Okay. Very good. And Sudi, I'm going to ask you to help me with that if you could, please. Can you blow up the right hand? Jen, I'm going to ask you to help me with this. Could you blow up the right-hand portion, which is just next to the blue exhibit tag? Right there. Okay. And Ms. Rosenfield, can you see who the name of this patient is, please?
Yes, it's a little bit difficult to make out, but I think I can.
Do your best.
It looks like Lana Clarkson.
Okay. And there appears, it's gone. There appears to be a date underneath that. It looks like April 5th of 1962. Is that correct?
Yes.
What date would that be?
The birth date.
Birth date. And that would be the birth date for Ms. Clarkson?
Yes.
Okay. And Jen, could we have, shrink that, there we go. And can you blow up the next section just below that, please? There we go. Now, there's three areas here that I want to discuss with you for a moment. The first one is entitled Admitting Diagnosis. You see that, do you not?
Yes.
And can you tell us, it looks like it's the word bilat, comma. It looks like wrist. What does that say? Can you tell me? You're probably going to be a lot better than I am.
Bilateral wrist fracture.
Okay, what is that?
That she had fractures on both of her wrists.
Okay, and then underneath we have the next line is entitled Symptoms Necessitating Hospitalization. And what does the cursive writing there say?
It looks like bilateral wrist pain.
Okay, and below that there's a third section entitled Patient's Goals for this Hospitalization. And what does the cursive writing say there?
2, and I'm not sure what that second word is, and then it looks like no pain.
Okay. Now, Jen, if you would help us here and shrink that back down, and then if you go over to the left area where it says other, would you please blow that up? Yes. All right. Now, that's another section on this particular part of defendants E11, correct? That's another part of E11?
Yes.
Okay. And what is that part? Can you tell us?
Looks like the medications that the patient is taking is being listed there.
And the person who prepares the patient profile would be one of the employees at Cedars-Sinai, correct?
I believe it's the physician.
The physician.
That actually does that, yes.
Okay, that's after the paramedics have brought her there and have now left, and now she's in the care and in the good hands of the Cedars-Sinai staff, correct?
Yes.
All right. And can you please tell us what that says?
Looks like it's written albuterol inhaler.
Okay.
As a PRN, that looks like, which means as needed, and underneath it looks like Paxil Q-Day, which is every day.
Okay. And now, Jen, could you please shrink that? And would you go down to the next section, which says substance use history? Would you please enlarge that? Thank you. Do you see that section?
Yes.
Okay, and again, that's entitled substance use history, correct?
Yes.
And there's three choices, and there is a box that is checked, correct?
Yes.
And which box is that?
It says alcohol.
And to the right of that, it says describe, and what does it say there?
It's difficult for me to read.
Okay, let me just suggest the word social.
It could be, yes.
Okay.
It's just hard to read that, yes.
All right, and where would that information come from? The patient?
Yes.
Okay. And now, Jen, could we please have the next 2 pages of Defense E11? And I'm just going to ask you a couple questions about these, and then I think we've completed our time together this afternoon. Okay. What is this document?
That looks like the dictation that the physician does after interviewing the patient and the course of treatment in the emergency room. And pretty much everything is spelled out as to what happened to the patient.
And you told us before you worked in the emergency room for many years, so you've probably seen lots of documents like this.
Yes.
Okay. And that's at Cedars, right?
Yes.
Okay. Highlighted, blown up and highlighted, please, at the very top. And this is just foundation. We'll move through it quickly. Thank you. Who is the patient?
Lana Clarkson.
Okay. And can you shrink that back down to the chin? And do you see where it says history and physical examination? Can you see that? Or Jen, can you blow that up, please?
No.
Mrs. Rosenfield. Thank you.
Oh, okay.
Okay. And it also indicates the date of admission, correct?
Yes.
And what is the date?
2/25/01.
Could you take a look again?
I'm sorry, 12/25/01.
That's all right. That's okay. So this is all part and parcel of the same admission when she was brought there by the paramedics, correct, on
Yes.
the 24th?
Yes.
Okay. And Jen, if you could shrink that, please. And could we have history of present, well, let's have chief complaint, which is the first line, please. And if you could blow that up and then highlight it. All right. And the chief complaint is what?
Bilateral wrist fractures.
Okay. And I just want to focus on 2 areas of this document. And this document, I understand, was authored by Dr. Brian Solberg, spelled S-O-L-B-E-R-G, Diana. Is that correct?
Yes, that's what it says on the...
Okay, and he was on staff in 2001 at Cedars-Sinai, to your knowledge?
Yes, yes.
Do you know Dr. Solberg?
I just know of him. I don't know him personally, no.
Okay, fine. And he actually signed this examination form, correct, on the back?
Yes.
All right, I just want to turn your attention to 2 other areas, and then we'll finish. Jen, could I please have past medical history blown up only? Up, right there. I need that blown up and highlighted. Can you highlight that? Thank you. Okay, and Mrs. Rosenfield, do you see that part of the history and physical examination report of Dr. Solberg?
Yes.
What does it say?
Significant for migraine headache, and that word's cut off, so I can't see that. Depression.
Okay,
I'm
well,
not sure what that,
let me,
looks like.
why don't you take a look at what it says here, maybe that'll help you.
Okay, and some depression. There's- Okay.
And that information came from who?
I would assume from the patient.
Okay. And Jen, can we please finally have the section below that entitled medications? And highlight it, blow it up and highlight it for me, please. Okay. And can you tell me what it says in that portion of the report of Dr. Solberg?
It says medications, Paxil and headache medications. She uses an albuterol inhaler.
And again, presumably that information would have come from her.
Yes.
And the court's indulgence. All right.
Thank you, Mrs. Rosenfield, very much. Thank you, Your Honor. Nothing further.
Just a few questions, thank you, Your Honor. In that same form, oh, they took it down, but in that same form you have in front of you, do you?
No.
Oh, we don't have it. Lana Clarkson just came in with 2 painful broken wrists, but Dr. Solberg describes her as a pleasant woman of her age, 39, right?
Yes.
Okay. And in the area of alcohol, it said social. I think we agreed on that, right?
Yes.
And in fact, if I would go to the baseball game with some friends and have a beer or two or have a glass of wine with dinner, I'd be a social drinker too. Is that correct?
Yes, I would consider that a social drinker, yes.
Okay. Just a couple brief questions. A couple names came up during your conversation or examination with Mr. Rosen. John Little, who's he?
It's a fire chief for LA City Fire, and he works in the arson department.
And liaison between you and the district attorney's office in obtaining the tape and the documents we talked about.
Yes, he assisted with that, yes.
And Gene Daly is a deputy district attorney who works with the fire department with arson. Is that correct?
Yes.
And she helped with that too?
Yes, she also assisted, yes.
All right. In fact, they've been kind enough to help you get here, right?
Yes, they have.
Lastly, and of course, as Mr. Rosenblatt, you're the custodian of records not only for that base hospital form, but for the tape, right?
Yes,
Okay.
correct.
And in discussing some of that, Mr. Rosen suggested at one time, and maybe you corrected him, that the nurse, at least in our situation that we've been talking about, Nurse Lovett, was kind of like a telephone operator just taking down this information, kind of like a 911 operator taking down information.
Yes.
Is that correct?
No. The mobile intensive care nurses are trained nurses, gone through special education to be able to help with the assessment and determination of a patient's treatment in the field. So they're highly specialized nurses and are familiar with pre-hospital care setting and what goes on in the pre-hospital care.
They're not only RNs, but they have special training
Yes.
in emergency medicine.
Yes.
That means working with the paramedics.
Yes.
So they're on the phone or on the radio with the paramedics to bring their medical expertise in trying to assist the paramedics in helping the patient in the room. Is
That's
that right?
correct. Yes.
Thank you. Nothing further. Thank you. Blue Cross?
Yes, just one question to ask you.
Yes?
Thank you. Just one question. Mr. Didden asked me about the drinkers, and I think you mentioned going to a Dodger game and having a beer or going to have a glass of wine and dinner. In December, particularly December 24th or 25th of 2001, you didn't know Ms. Clarkson and you had no idea how she defined the word social, correct?
Correct.
Thank you. Nothing further.
Can you redirect?
No, thank you, Your Honor. Nothing further.
All right, subject to recall, your excuse. Thank you for being here. You may step down. Yes? And also to accommodate a juror. Congratulations, by the way, to the juror. Birth of a new baby. Well, if you tell me it was conceived during the trial, that we haven't been here that long.
Not until they celebrate the first year birthday.
It only seems that long, which gets me to my next point. As you know, tomorrow you'll be here The sheriffs will take you out to the Grandview address for the view. Please remember, we're there for a jury view. I will give you some heads up. In the residence itself, and remember, this is a residence. It's Mr. Spector's residence. There will be some pictures that have been introduced into evidence in the locations that you will be viewing. They will help you orient what you've seen in the pictures as to what you're actually seeing there. In other words, where you'll be, there'll be pictures that correspond to what's been introduced in evidence. Once you've had a chance, and because where you'll be viewing, some of the locations are somewhat small, it'll be done in sets of 6. Each of you, there'll be 6 to a van tomorrow, and then we'll take you through. At some point, I will be inquiring, and please remember, this only goes to, as you're out there, if you need to see something or whatever, I'll be checking with you. This will be on the record as to whether there's something where we're located that you need to see, and I'll make a decision as to that. You'll be brought back here for lunch. After lunch, when we come back and reconvene at 1:30, I will be able to give you a good estimate of when this trial will end. The attorneys are going to tell me tomorrow all the remaining witnesses. Decisions will be made on who's being called and who's not being called. And based on that, I will be able to give you some fairly good idea of when we will be able to finish. So with that in mind, keep it, yes, juror number 2.
I recognize the name of the exhibit today.
What was that?
As a family friend.
As a family friend of yours?
Yeah.
Who was that?
Dr. Sabag, that was in defense of the 11.
Okay, does that have any impact? Thank you for letting us know. Does that have any impact on your ability to fairly impartially judge this trial?
No.
Okay, does anybody wish to be heard as to that?
No.
Okay, anything else? So we'll see you tomorrow. I believe you should be here at 9:30 in the morning. You'll be leaving shortly thereafter, and we'll go from there. So with that in mind, keep in mind the admonition. See you at 9:30.
Before they leave,
Yep.
did you want to keep the meeting?
Well, you might want to, Mr. Rosen makes a point. I don't know how much, we went out, we've seen the scene already, but there may be a small, and I do mean a small amount of walking. You may wish to dress comfortably, and especially comfortable shoes. I don't know that that's going to be that important, but it's not a bad idea. Okay? With that in mind, 9:30 tomorrow. Okay.
Okay, guys, that's it for today. I will see you guys again in the morning at 8 o'clock. And I think we have, I don't know who is tomorrow. We have some stuff outside of the presence of the jury. And then, I don't know, I didn't look, but I know coming up very soon we have, is it Michael Bodden? Is that his name? Um, and he has a very, very long examination. I think it's like 11 parts or longer. So he's coming up. I have no idea. What is he? Like, is he a forensic pathologist too? Okay, I'm gonna look. Well, I hate when this happens. Okay, I'm gonna share it so you guys can look with me. Okay. We have done all of this. And this trial has no rhyme or reason to it. There's no defense case and prosecution case. It's just whoever does a witness whenever in this. I've never seen a trial this wonky before. It's whoever, and then we're getting rebuttal witnesses before defense finishes their case. It's crazy. This trial is nuts. I think we're getting more Werner Spitz later too. That dude was ridiculous. Okay, there's Nick Terzi, and there's Michael Bay. Okay, there's Jan Leestma. That's the one we saw this morning. Pauline Rosenfeld, we just saw outside the presence of the jury. So that'll be tomorrow. Oh, we get James Pex again. 2 of him. Michael Baden. 1, 2, 3. Wait a minute. Oh, they don't count that as 3 because that's outside the presence of the jury. So 1 and 2 outside the presence of the jury. 3, 4, 5, 6, 7. Oh, and then he's going to get interrupted by Eric Peticha, whoever that is. Then more Michael Baden. Then outside the presence of the jury. Michael Baden, part 11, outside the presence of the jury. Outside the... Yeah, he only has 11 parts. Yay. Devra Robatelli has 2 parts. Dr. John Andrews has 4. Daniel Stark is back, the paramedic. Werner Spitz comes back. Good Lord. Pumpkin comes back. And Jennifer Hayes. Good Lord. Yay! Closing arguments. Look at that, guys. We're almost done. There's less to go than what we've already done. So we're over halfway done. Yay! Oh, I don't know how much longer this is going to take, though. I'm so tired. I need a vacation. That's what I need. I need a vacation. I need 2 weeks in a cabin in the mountains. Just to do nothing. Just to rest and do nothing. Okay, guys. I will see you in the morning at 8 o'clock for more Phil Spector. Love y'all. Remember, be kind to people. Love your family. And Jesus loves you. And so do I. Thanks for coming out. I'll see y'all in the morning. Bye. Have a great day.